I'm a, your- I'm attempting to be your technical moderator today, and as a reminder, this is a public meeting and it is being recorded. This is sort of our sound check slide. I'm going to look at the attendees, and most folks have already renamed it themselves to include where you're from. It just helps us later on. As we go, please have your microphone muted from your side as we're going. It just helps with background noise, but feel free to unmute yourself at any time. If you're not comfortable unmuting and just jumping into a conversation, feel free to raise your hand. It's under the little smiley face icon here, and one of us will do our best to acknowledge you before we move on. Feel free to send questions or comments at any time. And of course, that's the Zoom meeting is set up so that you can see everybody else that's in the meeting. And now I would like to introduce our facilitator or pass it back over to Vicky Lowe.
Thank you, Mike. And I'm going to pass it over to Jennifer Lapointe.
Good morning. I'm Jennifer Lapointe. I'm a member here at Swinomish and the general manager of the tribe. So I want to welcome you here this morning. We're happy everybody that could come in person to Swinomish. We're happy to have you. It really is good to see people in person now and again. We're happy everyone who could also join on the Zoom, but you are welcome to come out here next time or anytime. Give us a call. We'll show you around. Um, anyway, welcome here this morning. I think there's going to be a lot of good work today. Like I said, we're excited to talk, and I know there's a big transition coming kind of for all of us here in the very near future. And it's been many years since we've had to think about this kind of transition. And I think some have never had to think about this type of transition. So I'm glad that we're meeting today and getting to kind of talk through the logistics of that. So welcome to Swinomish. And Rosalie from Lummi Nation has kindly offered to offer our opening prayer for us today. So I'm going to let her go ahead and take care of that.
Good morning, everyone. I'd like to thank each and everyone for being here, and I'm happy to be here today to listen in on this meeting. And thanks for having me. But I ask, good Lord Jesus, to be with us today, to guide each and everyone that's working in the field of the helping field of health. I've worked in there for 40 years in the chemical dependency program. And I thank a lot of you people that are working here probably help with the care program and the health department. And they that wait upon the Lord will soar with eagle's wings. They will run and not grow weary and walk and not grow faint. And I'm saying this little short prayer for each and every one of you to be strong, to work through these, to help our people that are suffering with the opiate epidemic. And it's not just Lummi, it's throughout the states. Thank you, Jesus, for being here. Where there's two or three gathered, you are in our midst. Amen.
Good morning, everybody. All of you online. Welcome to our GIHAC meeting. My name is Summer Hammonds. My Indian name is Lahus. I'm a Tulalip tribal member working in the Treaty Rights and Governmental Affairs Department as a legislative policy analyst. I'm also the vice chair of the American Indian Health Commission. So we just want to welcome you all. And we really want to thank Swinomish for hosting. We really appreciate it. And so I wanted to call to order the meeting and turn it over to Maureen for roll call.
Thank you, Summer. Maureen Kinley, council member for the Lummi Nation and secretary of the American Indian Health Commission. So I'm going to start with roll call. Confederated Tribes and Bands of the Yakama Nation. Confederated Tribes of the Chehalis Reservation. Confederated Tribes of the Colville Reservation. Cowlitz Indian Tribe. Ho Indian Tribe. Jamestown S'Klallam Tribe,
Brent Simkowski, present.
Kalispell Tribe of Indians, Lower Elwha Klallam Tribe, Lummi Nation is here, Makah Indian Tribe, Muckleshoot Indian Tribe, Nisqually Indian Tribe, Nooksack Indian Tribe, Port Gamble S'Klallam Tribe, Puyallup Tribe of Indians, Quileute Tribe,
Jolene Winger, present.
Quinault Indian Nation, Samish Indian Nation, Sauk-Suatal Indian Tribe, Shoalwater Bay, Skokomish Indian Tribe, Snoqualmie Indian Tribe, Spokane Tribe of Indians, Suquamish Tribe, Squaxin Island Tribe,
Lucy Hill for Squaxin.
thank you. Stillaguamish Tribe of Indians, Swinomish Indian Tribe is present.
Present.
Tulalip Tribes of Washington,
Present.
Upper Skagit Indian Tribes, Native Project of Spokane,
Here. Sorry.
Seattle Indian Health Board, Indian Health Service, Portland area,
Present.
IH, what was that? Oh, yeah, IHS. Okay, I'll scratch that. IHS Colville Service Unit, IHS Welpanet Service Unit, IHS Yakima Service Unit, American Indian Health Commission,
Present.
Northwest Portland Area Indian Health Board,
Present.
State Senate Majority Caucus, State Senate Minority Caucus, State House of Representatives,
I'm here.
was that Chris? And Gina Mosh, is it Brooker?
Mossbrucker.
Mossbrooker,
Yes, present. Happy to be here. Wishing I was there though. Maybe next time.
thank you. Molly Boris from the Governor's Office,
Hi, good morning. I don't know who you have on the list. Molly's not here today, but Amber Leaders from Governor's Office.
okay, thank you, Amber. Department of Children, Youth, and Family Services, is it Tina Ives?
Yes, good morning. Talina Ives here, and we also have Bob Smith from Office of Tribal Relations with DCYF. And my apologies, I have to step out for just a little bit, and Bob will fill me in if we miss anything. Thank you.
Department of Commerce, Michelle Gladstone.
Good morning, Department of Commerce is present.
Department of Corrections, Jeremy Barclay or Colleen Costin.
Jeremy Barkley is not with Department of Corrections anymore. Colleen Costin will be joining soon. And I am here present Harjalik with Department of Corrections as well.
Department of Health.
Good morning. This is Colleen. I am online.
Okay, thank you, Colleen.
Good morning. This is Kristen Peterson, Chief of Policy here in person with Executive Director Candace Wilson of our Office of Tribal Public Health and Relations, and Rosalinda Turk, who's our Tribal Engagement Director.
Thank you. Department of Social and Health Services.
Quets Chen, Tim Collins, Senior Director of the Office of Indian Policy. It's great to be here. Thank you.
Thank you, Tim. Healthcare Authority.
Hi, this is Sue Birch. I'm the director of the Healthcare Authority, and I have a huge team with me. Lou McDermott, our deputy, is on. We have Tisha Kirschbaum, our Office of Behavioral Health. We did have Dr. Fatinas, our Medicaid director. She is on a federal call, but we'll pull her back over. And I know there are many others from our team.
Thank you.
Good to see everybody.
Thank you, Sue. Office of the Insurance Commissioner.
Good morning.
Good morning, Jeannie Lockhart. Oh, sorry, Jane, to step on you. Jeannie Lockhart also here in lieu of Deputy Commissioner Todd Dixon.
Right, and Jane Byer from OIC here as well. Good morning, everyone.
Thank you. Office of the Superintendent of Public Instruction. We have a Chris Reichdahl or a Henry Strom. Washington Health Benefit Exchange.
Yes, here. Manny Santiago, Chief of Equity, and Carolyn Abrahamson, our travel PSO.
Thank you. Tribe. 7 tribes present. We need 12 for a quorum. Are there any tribes online that I may have missed?
Have you counted Swinomish?
Yes, thank you.
Yeah, at this moment, we're going to move on. We know that we don't have quorum, but we're going to have Auntie Candace and everybody get out their phones and start texting others. Yes. And yeah, I just want to thank everybody for showing up today. I'm really excited. We have a great agenda. We have the governor's office transition planning, and I'm just going to go through briefly. And then when we meet for the administrative business at 11:30, we have the opioid treatment in Indian country. We have the Swinomish Indian tribal community presentation. And then we're going to break for lunch. And around 12:30, we're going to go into the legislative health priorities. And then 1 o'clock, we're going to talk about the 2025 Washington State Capital budget investments. And then we'll adjourn around 1:30 with a possible tour at Depot Beach. Yes. So I'm going to turn it over to Amber Leaders and Samantha Paskowski from the governor's office to talk about the policy staff for health and behavioral health. They'll share the information on the transition plan for the new governor in January 2025 and gather input from tribes and UIHOs.
Thanks so much. I really appreciate the opportunity to be here and to be with all of you. I'm also sorry I couldn't make it to Swinomish, but hopefully I can make it up again sometime soon. I'm going to keep my remarks relatively brief, and then we'll allow, some time for questions. Sam is here as well from the governor's office, and so I think most, as was mentioned, I think this is mostly to start gathering some of the things that we should have on the list as we're working towards transition. In terms of what our office is doing, so there's a number of different things that are happening. We're certainly making plans within the governor's office itself for transition, for briefings. Governor Inslee will do a final budget before the biennium that we'll be working on this fall, and we're getting agency requests and decision packages coming in September. Our agencies are also working on briefing packets and putting together particularly significant pieces of information that will be available to the new administration, whoever that may be, when that is determined. One of the things that we don't know at this time, as I understand it, is that it is really up to the new administration how much they want to engage or not. We will make materials available. We will make staff available. We will make those offers, but it will really be up to the new governor and their team to decide how much they want to engage on particular topics. But we will be creating kind of a punch list of the items that we think are sort of the top issues, and we'll certainly include some of the things that we have talked about here in these meetings in the governor's Indian Health Commission. So that's a really quick overview, just in terms of what the plan is. Sam, I don't know if you have anything you want to add, and if not, then I think we're both available to take questions and kind of talk through the things that we should make sure we have on the list.
Thanks, Amber. I don't have anything to add. I think I'm interested to hear what might be most helpful for folks, what questions folks have in the room and online.
Right. And really quick, this is Jane Byer from OIC. We too will have a new commissioner in January. So if there are issues related to the world of private health insurance that you'd like to bring to that person's attention as we're doing our transition planning documents, we'd love to hear it.
Yeah, and I will just, one other quick comment. Thanks for chiming in, Jane. I appreciate that. We do have some of our agency leadership here too. I think they are also available. Their teams are doing a lot of work towards transition planning as well for each of the individual agencies. I see Brent. Do you want me to call on folks with hands up? I'm happy to.
Yeah, that would be great.
Okay, can do. Brent, go ahead.
Yeah, hi. This is Brent Simkoski with the Jamestown Tribe. I guess the question that comes up, and it's always hard to answer this because we don't know who's going to win, although we can kind of look at the primaries and guess. But the concern is always about what's going to happen with projects or initiatives that are sort of starting or underway when a new transition to the governor's office comes. For example, I'm thinking about Medicaid 2.0 or whatever we call it. That's just now starting, even though the funding goes back a year. Most of us are just now starting that. I don't know how much Bob Ferguson knows about the Medicaid transformation projects. And I think there's a whole lot of other issues around OTPs and the fentanyl crisis. And will there be some meetings, I guess, after the election to kind of assure us that there's not going to be this wholesale? The last thing that drives us crazy at Tribes is we like consistency when we move from one group to the next, and we don't want to have to be starting from scratch and reinventing the wheel for every new elected person in office.
Yeah, good. It's a great question. It's one we get all the time. And so I think we're doing a number of different things. Some is putting together the written materials of all these things, exactly the kinds of things you raise. Brent, some really significant pieces of work, and we'll make that available. I know we've had for example, at the Tribal Opioid Summit that we held in Spokane, there's been a specific ask to make sure that there's a conversation between administrations related to tribes and the work we've been doing on the fentanyl and opioid response. And that certainly will be on our list to make a request of the new administration. The other thing I would say in terms of preserving continuity is that we will have our agencies all fully briefed. So a lot of your agency staff who are working on these issues in partnership with the governor's office and with tribal governments and others will still be here, tribal liaisons and others. In terms of the turnover, there is, likely to be quite a bit of turnover in the governor's office itself, less turnover in our agencies. in terms of what's happening there. And so there'll be a lot of continuity that'll be preserved through our agencies. And I saw Sue pop on, and I didn't know if that meant she had some other comments on this.
Yeah, I just want to say that from healthcare authorities' perspective, the work that we have ongoing around our engagement with individual and community health goals, about health financing and accountability, about all of our digital and IT plans and inclusive, equitable systems, all of this is going to continue. This work is so important, and regardless of the leader who finally comes in and or the person that sits in my chair in the future, this work will continue on. It's key to transformation, and we remain really committed and will continue to stride along with our tribal partners to just really keep our health transformation progresses going, especially with all the significant community behavioral health transformation work we're doing. So change is hard, but we are prepared for easing as smooth a transition as possible, and we are here to support tribes and everybody as we go through this. I personally will not be renewing for another 4 years, but I have assured this governor and the next governor that I will have as smooth a handoff to a future leader as possible. And my heart will always be with Washington. I just have a new grandbaby coming, so I need to open up these arms to hold a baby a little bit more. But I will be working at the national level and also behind the scenes to keep clearing obstacles so Washington can keep being a pace setter in the nation. And I'm confident that whatever color administration gets in, red or blue, we will be pushing for the balanced kind of health transformation work that we always have. So, and tribes are critical partners in all of this work. That's it for me, Amber.
Thank you. Thank you, Sue and Amber. There's some questions here. I'm going to turn it over to Jennifer, and then I want to turn it over to Rep. Stearns next because he has a question about the request for legislation.
Thank you, Jennifer LaPointe, Swinomish Tribe. I guess one question, is there any projected date or time when these briefings will be released for the transition plan? I guess we would like to see more details on that sooner than later. And then I think it kind of dovetails on your little announcement there, Sue. I guess the reason we'd like to see those ASAP is because I don't think it's a secret. I think that it's very, very common and expected. I'm sure throughout the state agencies, there's staff exiting now and going to be exiting between now and January, just knowing that there's going to be a change, no matter what that change is, looking for more stable positions or things like that. So I think the sooner we could see kind of the black and white of the transition plan and know how to, I guess it's hard to say prepare because I feel like we're already in it. So more details sooner than later would be better. And if any of you have any comments, I know you may not be able to make these comments, but if you have any comments on what your plan is, if your staffing gets kind of light because of the pending transition coming, as far as our progress between now and January, not just after the transition.
Yeah, thanks for that. I will go back and double check exactly what the timelines are. I don't want to speak and give the incorrect information. I know that work is well underway and has been now for a couple of months. And so my best guess is that that's coming due here relatively soon. But let me verify the actual date, and I'll give some information back to Vicki Lowe that we can share back out in terms of timelines.
I just want to share that from the healthcare authority's perspective, we don't anticipate other senior leadership transitions or key division director transitions. And anybody that's leaving the governor's office that has been passionate about this work, of course, we're going to try to pull them in somehow, some way, but time will tell. And again, I just want to reiterate that the work is so important and it will continue. And we are not anticipating massive leadership transitions.
Thank you. I was going to turn it over to Rep. Stearns if he's still online. He has a question about legislation.
Hi, thank you. Yeah, this is really helpful. I was just sort of curious about what should be our expectations regarding the agency request legislative process.
Yeah, thanks, Rep. Stearns, for that question. It is a little different than usual, though it will look largely the same. So our agencies are right now, along with their decision packages, working on agency request legislation. That will get submitted to our office as it has been in the past in about September. And the Inslee administration will review and do sort of our standard process for agency request legislation that comes through in terms of approval or not, working with the agencies on additional stakeholder work, refinements to the bills, and other things. The thing that's a little bit different is that regardless of what the Inslee administration does or approves in terms of agency request legislation, the new administration will also have an opportunity to review and provide feedback on whether or not that agency request legislation will continue to be supported for a new administration. So one of the things our office is doing is we're doing a lot of work with legislative partners so that if there's things that are kind of coming through our agencies that we would like to see continue through the legislative session, working with our legislative leaders in terms of making sure they're aware of that legislation and working in advance with legislative partners on what those things might look like. But there is this sort of additional layer of review and conversation that will happen this year that's different from years past.
Thank you. And I did have a question. I really appreciate all the questions in the room. I know that the Centennial Accord is coming up, and so some tribal leaders have been asking too about the governor's transition plan on various subjects. So I noticed that it says on here to gather input from the tribes and UIHOs. Is that in today's conversation, or will you be putting out information for tribes to give feedback and then possibly put together a report before the Centennial Accord so that tribal leaders can engage on, knowing that there'll be a smooth transition?
Yeah, and I don't know if we have anyone from Governor's Office of Indian Affairs on here who might have some more information on that. But I would say, I think Sam and Molly and I, regardless of what the plan is related to the Accords and others, we would be interested in feedback from the members of the American Indian Health Commission and the tribes who are here, and the tribal leadership that's here in terms of things in the healthcare space. That we would want to have as priorities for the transition. So there may be a separate process at the Accords as well, but certainly in the healthcare space, I think we would still want to do that either way. And I don't necessarily expect people to have their list prepared today. I think this was just an opportunity to kick off the conversation so that we can start building what that list might look like.
Amber, if I could just follow up with
Please.
a more specific agency perspective. Because it's twofold. Not only, Rep. Stearns, are we moving forward with our decision package requests that are specific to the major initiatives, things I think you would certainly anticipate and or might be knowledgeable about. We can't discuss those. But we are also working very closely with our federal partners who are buttoning up a lot of their work in case there are transitions there. So that's equally as important because of the significant match opportunities. So, for example, yesterday, our federal partners, we have for 5 years been working on the HC Max, the care management systems, and they awarded the next step of approvals as we move forward with getting behavioral health IT infrastructure. And so this brings in enormous federal resources to the state agency, and the legislature is very aware and involved through WATEC and whatnot. So we also have a very targeted list of things that we are asking our federal partners to either sign off on, close up in case there's transition there as well, so that we are not having timeline disruptions in some of the very progressive work we're doing around community behavioral health and cost containment and affordability and a number of the IT. So I just think too, from a federal perspective, since we anticipate even maybe some different leadership prioritization of projects. We're trying to close up or secure the things that we know are still being negotiated.
Are there any other questions? So what I'm hearing is that AIHC will help put out information so that it could give tribes and the UIHOs access to turn in their input. Does that sound good? Perfect. Is there more to your presentation, or does that conclude it? And also, is there any other questions from your end for the leadership in this room?
I don't think I have any questions at the moment. I think we really look forward to hearing from the leadership in terms of areas of priority and things that we want to make sure we get on our list. But no, that concludes our presentation, but certainly always available if there's any follow-up questions or anything.
Okay, perfect. I have Sarah who has a question, and then I'll turn it over to Vicki, who also has a question.
Super quick question, actually following up to Sue Birch's comments for the different timelines. And I know you said you're working especially with the federal agencies to kind of close up some pieces. Do you foresee any issues with certain awards or projects where maybe they're ending in 2025 or 2026? Is that a list of things that you all are focusing on and prioritizing, or does everything really fall under, okay, it's the end of 2024 and maybe we don't have to worry about for a couple of years to give the new governor enough time to kind of follow through with understanding kind of where we're at with other projects that may end, years from now?
So the ones I were referring to were more in the 24-25 timeframe. I do think the one that is probably the most concerning to all states in the nation are the federal subsidies that could end with a significant change in the administration. We don't know that, but we anticipate that the subsidies for the health benefits exchange could be going away out into the future if there was a swing politically. So that is one that I think the Exchange Board is monitoring and trying to educate on. But there aren't any right now that I can think of that imperil our work. I will tell you, many states are continuing to follow suit with many of the things we've done with supportive housing and our community behavioral health investments and the equity work that we've done. So the problem is really the pipeline at the federal approval process is getting longer and longer. So that also is a little concerning because it just takes them longer to clear things that we need done. But I guess that's good that others are replicating our work, but it's just a pipeline issue of what they can get done and cleared. But I'm not anticipating anything that would really unravel our work.
Good to know. Thank you so much. I appreciate all your and your staff's work.
Vicki?
Good morning, Vicki Lowe, Executive Director for the American Indian Health Commission. I just want to add that at the Tribal Opioid Summit, we did have kind of a planning meeting for the Centennial Accord, and Craig's not on, but some of the things that we talked about was like this body, Governor's Indian Health Advisory Council, is in RCW 4371B, but the Governor's Tribal Leaders Social Services Council is not. And what does that mean? And also, there's just been a change in the work between the agencies and the tribes, and we've really gotten a lot more tribally driven. And I know that was kind of the intent of the Centennial Accord and the Millennial Agreement. I feel like we were discussing how we've really gotten more there in the last few years, especially through COVID, when the tribes and the urban programs really stood up and helped with the response. I just don't know how to make sure we carry that forward. And that was one of the things that we thought we'd talk about in the pre-session and the planning session on the 19th. So just putting that out there too. It's just that there's been, so much good stuff that's happened in relationships. And I know we're worried, Sue, we're going to miss you. But I understand grandkids. But and that's not codified and it's not in policy, but it's something we just want to make sure that we carry into the new administration. That makes sense. So that I think we'll be talking about that in the pre-centennial accord meeting.
What date is that again? The pre-centennial?
September 19th. Okay. It's the 19th and the 20th. So the pre-meetings are the 19th.
So I was wondering if we could get any tribal engagement from AHC to them so that by the time of the 19th, we have some ideas from tribes, what they'd like to see in that. And turn it back over to Vicki to give us an update on forum.
We have, excuse me, this is Colleen Costin with DSC. Tim Collins and I do have a meeting that we've scheduled for Monday as a pre-meeting for the Centennial Accord, recognizing that having a conversation for 2 or 3 hours the day before the Accord would really make it difficult on this huge human services spectrum to have a completed dialogue. So if anybody would like to join us on Monday, we do have quite a few tribal leaders and tribal chairs that have responded. They'll be joining us on Monday. Just shoot Tim Collins and I an email and we'll send you the invite to the meeting it's a virtual meeting on Monday, this coming Monday. Thank you.
What's the title of that meeting again and who did it go out to?
I don't know who asked the question, but this is Colleen Costin again. It's just entitled Pre-Centennial Accord Meeting, and it could have came out from Tim Collins or myself. And we sent it to all of our IPAC, SIPAC, tribal chair delegate lists. And we did reach out to you, Vicki, to see if you would be able to join us or not from AHAC. Again, we just want to start the dialogue knowing that 2 or 3 hours the day before the Accord will make it difficult to really encapsulate that human services spectrum.
I wonder if would be good to have a tribal caucus before the planning meeting. And I know we still need to have one for the Native Hub too, so maybe we can combine that. So maybe like the second week of September, after our delegates meeting, we do a tribal caucus, and that will prepare us for the planning meeting at the Centennial Accord.
And this is Aaron Spark from the Healthcare Authority. I really would appreciate that because I think we're having our state meetings. Thanks, Colleen, for bringing up the meeting on Monday. I can't attend, but Chrissy will be there. But after the caucus, if you can give us a list of questions that you think you want answered at the Centennial Accord, that would help the state agencies.
All really good input. I appreciate this dialogue. And then so it looks like Vicki will help streamline that process. So Vicki, do you want to give an update on quorum?
Yes. Thank you everybody for texting. We now have Quinault, Liz Brown, Seattle Health Board, Christina Diego, Stillaguamish, and Nicole, I think it's Tina.
Hello.
I don't see her. Oh, there you are.
I didn't catch your statement. What was it?
And Skokomish, Puyallup, and Cowlitz. So that gives us a quorum.
Awesome. We have quorum.
Thank you for joining.
Yeah, thank you. So with that, I'm going to ask Vicki or her team to pull up the minutes. We'll pull up the minutes first from April 30th. And I'd like you guys to look that over, and then we would need a motion to approve the minutes.
This is Mike. Vicki, am I sharing the right screen?
That looks like today.
It is today. I'll see if I can find the minutes.
There's a link in the slides to the agenda, to the minutes, sorry, on the right there.
It's coming up. 21st century technology is so cool.
Great. Yeah, so we'll scroll down the April 24th meeting, sorry, April 30th. And I'd like to invite anybody to make a motion to review them, to approve the minutes.
This is Brent Simkoski with Jamestown. I make the motion, we approve the minutes.
Thank you. Let me seconds. Thank you. All in favor say aye.
Aye.
Any objections or abstentions? Let abstains. Oh, okay. Let me abstains. So we're going to pass the motion with one abstain. Thank you. So now we're going to go to the agenda for today. Are there any changes to the agenda? Do I hear a motion to approve today's agenda?
This is Brent Simkoski at Jamestown. I'll make the motion to approve the agenda.
Thank you. Can I get a second?
Well, you will second.
Eliza Brown for second.
Thank you. All in favor say aye.
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 Thanks. Any opposed? Any abstentions? Motion passes. Great, we're getting a lot of work done. So I'm going to turn it over to Vicki to talk about the tribal reinvestment account update. And then right after that, we're going to go into a discussion about the Tribal Data Sovereignty Committee update.
And I'm going to turn it over to Aaron because he has some good news for us.
Yeah. My name is Aaron Spark. I'm an enrolled member of the GIHAC Native Village Kashunamute Tribe, and I'm the Office of Tribal Affairs Administrator at the Healthcare Authority. Thank you for having me, and thanks to the Swinomish Tribe for hosting the meeting on your beautiful lands. Always one of my favorite things to do to come out here. I'm not kidding. Also, my electronics immediately beep. They're like, "We're at Swinomish." They connect right when I walk in the door. So always wonderful to be here. And we do have some good news on the tribal reinvestment account update. Although I know it's many years late, the Washington Indian Health Improvement Act did pass in 2019. The ability to put money into the reinvestment account has been active since 2019, but due to the pandemic and a lot of reallocation of resources during that time to get money out the door and to address the pandemic, we hadn't progressed as we should have. So now we're at the point where the healthcare authority is very close to being able to issue full guidance for this. We're very close on a data sharing agreement for care coordination agreements. And that is the work of, I'm going to say, 6 different departments at the healthcare authority. Many thanks to everybody who spent a lot of time figuring this out for us. So we're very close. Of course, that doesn't preclude any tribe from not sending it in their contracts. And we did receive our first official contract for review from the Port Campbell Squam tribe. Unfortunately, there was only 2 of the elements of the 4 that were in the show, but this is growing pains. I think very soon it shouldn't take too long to work with their contracting team to make sure it includes all 4 elements. So we're very close to actually putting some official dollars into the reinvestment account. So we are progressing. I'm going to say that's good news. Again, this is many years late, so I do apologize for that, but we're going to get there. Lena can attest. The first thing I did when I walked in as the Office of Tribal Affairs Administrator was ask how much money is in the account, but that number wasn't there, and I thought we were going to be able to fix that very quickly, but that did take some time. So again, thank you for your patience. We also have Carl Yanagita on the line, I believe, from the Healthcare Authority, and Michaela Snook, who are going to give us an update about our accounting methodology of how the state is going to look at the reinvestment account for the tribes to consider how to disperse those funds annually after we do our true up. Carl or Michaela, are you on?
Yes.
Hello.
Wonderful.
Hello, everyone. I have a slide deck I would like to share, and I think I need some permission to go ahead and share this.
Hi, Carl. This is Mike Longnecker. I'll stop sharing and I'll let you know when I can see your slides.
Okay, very good. Thank you.
Carl, and if you could introduce yourself, please.
Yes, absolutely. Just focusing on getting these slides up and running. But anyway, my name is Carl Yanagita. I am the special assistant to the Chief Financial Officer here at the Healthcare Authority. I am accompanied here today with Michaela Snook, who's the section manager of the Office of Clinical Finance, and also with the Financial Services Division of the Healthcare Authority. And I do want to make sure that you are able to see my slide here.
This is Mike. I can see your slides.
Okay, very good. Okay, so we are here today because we do want to provide you with an update on the logistical side of the reinvestment account implementation. Erin already discussed some of the progress that was made in relation to the documentation and that's necessary in order to implement this. But there's also this logistical side that needs to be addressed within the budget process because we need to define how these calculations are going to be made, who's going to make them, and how the communication of those calculations are sent to the appropriate places so that they can be authorized and transferred into the proper reinvestment account. So from a fiscal perspective, this logistical challenge is rooted in the fact that the state treasurer really must be the entity that does transfers into the reinvestment account. And they will only act on what is authorized and what is appropriated. And this appropriation needs to come from the enacted budget bill each year. What this implies is that we need to align this methodology of calculating the savings and requesting for these authorizations within the existing budget development and enactment process timelines. And we must also ensure that we are able to describe and explain to the governor's office, the Office of Financial Management, and to the fiscal committees of the legislature so that they are comfortable enough with the methodology and with the calculations each year in order to include it in their budget proposals. So we came up with this methodology after a variety of different attempts that addresses these concerns, as it would use the already existing formal medical expenditures forecast and incorporate the calculation of projected reinvestment savings for an entire fiscal year and make that an integral part of the forecast. Now, for those of you who are not familiar with this process, our budget at the Healthcare Authority is the vast majority of it is defined by this forecast. And this forecast is led by the governor's fiscal arm, which is the Office of Financial Management, and includes other HCA staff, other governor staff, as well as a nonpartisan staff of the state legislature's fiscal committees. And they meet regularly during the fall and winter to produce a main October expenditures forecast that informs the governor's budget that is released in December. And then they update it a few months later in February, and that informs the final enacted budget that's passed by legislature in March or April of every year. And this annual forecast would have the proposals to have these savings calculations already baked into that forecast, which will then provide the necessary authorization that the state treasurer needs in order to transfer an entire year's worth of projected reinvestment savings into the account at the start of the next fiscal year. This process continues moving along every fall. The same work group will revisit the calculations of that original forecast. They will use financial data to determine really what actually happened in that fiscal year. And if there are any differences between what they projected and what actually happened, We would then be able to add those differences from the past fiscal years to the projected saving transfers amount for the next fiscal year. So this really, some of you may recognize this as a true-up process that will ensure that the savings transfer amounts from past years always align with what the tribes have actually earned. So I did want to also highlight why it is in why what benefits that this methodology does provide to the council and to the tribes, as well as to the healthcare authority and other decision makers. The first part of this is it does reduce the administrative burden to implement this process. Rather than creating our own standoff methodologies, which may or may not align with already existing fiscal timelines and processes, this process actually aligns itself naturally within the existing state budget process and timelines. This also means that we will be able to leverage existing infrastructure like the forecast work group, rather than having to build something on our own from scratch. Another benefit to this proposal would allow the council to plan for how it would distribute funding up to 8 months before the start of the next fiscal year budget. Because the budget for the next fiscal year, the forecast comes out in October, it gives time for that kind of thoughtfulness. In addition, this methodology would require that the amounts that are transferred in the fiscal year remain constant and unchanging for the full fiscal year. The benefit to this is that there's budget stability. The last thing I think any of us would want is to have plans that we were going to use for other methodologies, which would retroactively move money into the account, and find out somewhere in the middle of a budget year that you are short and need to maybe cut back on what your plans were. This gives a budget stability for a full year. And what will happen is that actual savings from the past fiscal year, if they differ from the original forecasted amount or transferred amounts, this proposal actually allows for that true-up process, and those adjustments would be made to the next fiscal year's savings budget. So that along with the fact that this naturally promotes the necessary transparency to how the calculations are made, this would be particularly important since the governor and the legislature, again, they need to bake these savings transfer authorities into their budget. And they need to therefore need to be comfortable with how they're calculated, and in a phrase, need to buy off on it. This promotes the buy off because we won't have to defend the calculations to them if they're actually a part of the calculation process themselves. Remember, they're part of that forecast process. So that is really something I wanted to present to you. Make sure you're all aware of how this is working behind the scenes. That is a process. I don't know if any of you have any questions on what we have. A lot of information that I went through quickly. So open to questions if there are any.
Thanks, Carl. This is Aaron. If we can also get a PDF of this and send it to me, and I can send it on to Vicky so we can send it out to the council.
Absolutely.
Go ahead.
Thank you. This is Senator June Robinson. Sorry if I
Yes, hi, Senator Robinson.
Hi. Thank you for that explanation. Will the legislature see these steps as we work through budget policy decisions, or will it, because it's part of the forecast, will it sort of just be done by the forecast group and be part of maintenance level budgeting?
Oh, that's a very good question, Senator. Thank you. The language that is necessary to authorize the state treasurer to transfer the funds has historically been within, I believe, Section 7 of the budget. And so I would anticipate that when the governor releases the budget, the proposed budget, in that section will show what that number is explicitly. It will be something that can be isolated and viewed within the context of that document. Is that the transparency or the that you were asking about?
Yes, and I mean, I think either way is that's a fine answer, and I wasn't necessarily saying we need more transparency. I was just trying to understand how it worked mechanically. Thank you.
It will be explicitly placed into the budget, since that is the necessary authorization that the treasurer will need in order to move the savings over to the account.
Thank you.
Hi, Carl. Charlene Abrahamson. Thank you for the presentation. That was really clear. I'm wondering on periodic or quarterly type of updates and situations, if there's payback or not, how much notice will tribes have if they're facing that at the end of the fiscal year? Thank you.
Okay. Let me see if I can repeat that question briefly to make sure I understand what you're asking. I think you're asking, is there going to be a way of being able to assess, even before the end of a fiscal year, how much over or under forecasted the transfer was? Is that the question that's being asked?
Yes, just so that tribes and the clinics have time to prepare.
Perfect. Okay. As I indicated in this methodology, the idea is that once the transfer is made into the account at the beginning of a fiscal year, that transfer doesn't change. However, in fact, we had just discussed this earlier amongst ourselves, that we will still need to have a process that assesses how, even before the next fall's forecast, how we are moving along and how actual savings are aligning with the past forecast. So the idea is that we would be able to do that, and actually we would be able to perhaps communicate, how much over or under we might be throughout the year, so that you could get up to a full year's worth of advance notice saying, hey, we actually, maybe here's a scenario, we underestimated the savings for this past fiscal year. The difference between what we're actually earning and what was forecasted and transferred, well, we will be adding it on to the next fiscal year's appropriation. And if that happens, that could happen. It'll happen at least 8 months prior with the new forecast in October, but it could even happen sooner if we are noticing some trends that are occurring.
Thank you so much. I'm not currently working for a tribe, but I do have memories working with the finance departments and trying to get that sorted out in state budget year, the tribal versus federal. So that's really helpful.
Understood. Thank you.
Vicki? This is Vicki again. And then remember that there's the Tribal Reinvestment Account Committee of the Governor's Health Advisory Council. So then they will get the report of those funds and make a plan for how the funds will get spent. And then that goes back to the GIHAC. And then does it go to the legislature after that?
I believe
GIHAC approves. Yeah.
If someone can remind me when the fall GIHAC Advisory Council meeting is going to happen, because I'm sorry?
It'll be the winter. It'll be in December, right?
Yeah, December 3rd is the third and final meeting for GIHAC.
Okay, very good, because the forecast, which is produced in October, sometimes it does bleed into November. It seems like that would be an appropriate time. In fact, maybe fits nicely into, that it would be reported at that December GIHAC meeting what the forecast has actually predicted and forecasted for the next state fiscal year. So it then gets the ball rolling, so to speak, as far as the council can start beginning to plan on how perhaps that would be distributed.
Right. And so this is Aaron again, and again, a plug to make sure that the Governors Indian Health Advisory Council tribal representatives at that subcommittee meeting, we do need that methodology of how the money is going to be dispersed. So once those dollars are approved and they're in the account, it is up to the tribes to tell us how that happens. So we do want to see some movement on that. Well, hope to see some movement on that by the end of the year. I know there have been some preliminary conversations, one when the legislation was written, and I know we've talked about it over the past couple of years. But I think at this point, the past 2 years we've talked about it. At this point, we're getting close to the need for the full-on plan for that goes. And there is still going to be a very big push by the HCA to talk with each of the tribes with any of your contracting that you have with your outside partners to make sure that you get those contracts into the HCA so we can start populating that account with those funds. Again, those funds are designed really for capacity and infrastructure for the tribes. We know there's very little funding for capacity and infrastructure that's out there. And that's what this is for, using those 100% FMAP savings to help you create your ideal system of health. And that's something that we're very happy to do with you. But again, that plan has to be formulated.
Thank you, Erin. Tony, you have a question? Your hand's raised.
Yes, and it's for Erin. I hope words have power. I hope you're using the language tribes and urban Indian health programs, but I would like to request formally a statement of the reinvestment fund. I mean, we've talked about it very generically and generally, but I would like to know specifically how much money is in each of the lines in the account, and that we get that accounting to this body at least every time we meet, that it's an agenda item. You know, how much is there, how much we've spent, what is it being used for, so there's really good transparency.
Yeah, I think what Carl had laid out, thanks, Tony. I think what Carl had laid out is that we're able to give that projection throughout the year. So I think that's fine. But the use of those funds is fully dependent on the GIHAC committee members. That does include the two urban Indian health organizations.
Yeah.
But I think as far as those projections go, I think that's something that we can do at each of the meetings to show what our projections are showing throughout the year.
Okay.
Are there any other questions? Any online? Well, thank you guys for that update.
Thank you for having us.
Of course.
So thank you very much.
Thank you. There's one more.
We have one more.
Oh, yes.
Just a quick question. And sorry, actually, it's not specifically on the funding, but how many contracts do we have currently amongst the tribes with healthcare authority that are put in place? Just the one at Fort Gamble?
Just the one that's been submitted. I know that there are plenty of contracts that are out there that have not been submitted. Yes. I'd love to see them in any shape that they're in. It's probably good exercise to submit them to us so we can put it through the legal process just to show the 4 elements.
I might want to hear from whoever, I guess, started the first contracts to figure out what's working and then what's not. So maybe you've been after a few months, if we could kind of check in with those and hear from them.
And I think we are going to do that. So once we have our guidance, once the data sharing agreement is done, we plan to have a soft launch at Port Campbell. We're going to do that in partnership with them because of all the tribes that are out there, they've been working with us more closely. So they have examples of both care coordination agreements and tribal FQHC affiliate agreements. So I think at that point, we'll be able to see some real-time data. And Maureen, sorry.
Yeah, I just had a quick question. Who are the contracts being sent to at the tribal level?
Any one of us at the Office of Tribal Affairs. So there is no wrong door as to who you're sending your contract to. Where we're going to store them, we are going to let you know that that is secure and only we have access to that along with fiscal and legal.
Okay, then at the tribal level, is this information being sent out to the health directors, chairman?
Oh, yeah. So when we do the launch, yeah, that will be sent out probably a little bit further, more broadly than just the council. So a little bit more along the health directors, behavioral health directors, and things alongside the council.
Okay, perfect. Thank you.
And to be clear, the contract is between you and the specialty provider, and you'll be sharing that with the healthcare authority so they can make sure it has all the correct elements to get the 100% FMAC.
And just to be clear on this, we only receive the care coordination agreements. The tribal FQHC affiliate agreement between the tribe and their provider, that's between you and the provider.
Great. I'm going move on to the Tribal Data Sovereignty Committee update. Is that you, Vicki, that's giving the update in partnership with
Yes.
GIHAC? Sure.
Yeah, we don't have a lot to update. We did have the first meeting. So the Tribal Data Sovereignty Committee was established by this body. Aaron mentioned needing data sharing agreements for the tribal reimbursement account. We've been working with DOH. We had something come up with the Attorney General's office. So I think Asa and Lucy are on here from the AG's office too, because it's, we need to get this work moving. We had the first meeting on August 2nd, and the committee wants to start meeting every week, every 2 weeks. That would have been today, but we already had this meeting. So starting next Friday, we'll be meeting every other week from 10 to 2, and that's the tribes, the urban programs, the agencies, and just to have a place to have those conversations to better understand why we need data, tribal data sharing agreements. How are the different agencies using the data? And then how will they communicate with the tribes about those data? So I sent out a string of invites. If you didn't get one, let me know. And I can add you. I've been having a lot of trouble with my email list because Microsoft did an update and I have to manually enter every person into a meeting instead of my contact list. So I apologize if I missed anybody. And then we've been working, we spent the last 3 years or so working with DOH on tribal data sovereignty or tribal data sharing agreement. And then also this tribal data use form. And I think, do you want to have that conversation now, Kristen, kind of about how that works? So, okay, I'm going to stop and see if there's any questions about the committee.
I really wanted to ask any of those that were at the last meeting what they thought of it in the direction, because we were all nerding out, right? So I want to hear a few testimonies or something, Sarah or anybody else online.
Oh my God. Yeah, I kept saying, okay, hold on, let me walk back and do my public health data nerding. So no, I think it was a really good conversation. What one piece I want to make sure every tribe is very aware of, and I didn't know this until we had the meeting, was all the different data points that Department of Health had on a PDF of everything that they collect, have access to, for us to understand, well, what's your current data system look like, and what's included in there, and running into maybe some issues of data limits that we might see already. But I think we also opened up the data sovereignty committee to, anyone who works, in any tribal health system, who understands and looks at the public health side, the data side. But it was really helpful, I think, from the Department of Health, understanding, well, what do you guys have already that we needed to know, and have a specific list of what we can actually obtain when we get to that data sharing agreement or data use form piece, and what that process looks like, because we got to know what we have and how often we can access it, how specific, whether we can get down to the patient level, or maybe it has to be more aggregate because of, certain requirements in the system and who has access. But yeah, I think it was a super good start to the meeting, because we got to learn about the current systems in place first, and the state's process, and then kind of move on our recommendations.
And Amanda Chimson from DOH just shared that document that Sarah's talking about. It is in the chat box if you want to look at it.
Maureen, did you have your hand raised earlier? Oh, okay.
And so for the first meeting, we were going over the elements of a data sharing agreement and working with the tribes to find out, what you all think is important to have in there. So Jessica also put the link to the survey in there that has those the pieces of the data sharing agreement and the checklist that we were going through, if anybody wants to look at that.
Great, Kristen.
Did you want me to talk a little bit about the form or the request?
I think that, so I'll just talk a little bit more. I'm sorry. This is Vicki again. So when we started having these conversations with DOH, it was during COVID, and the tribes and the urban programs needed access to those positive COVID tests, and there wasn't a process for that. The local health jurisdictions had to access, but we couldn't get it for the tribes, so we kind of made that work, and not in the best way, because it ended up being only read only. And so the tribal staff could not go in and actually enter the information. They had to, I think, send it to the local health jurisdictions. And it was a huge workaround that obviously could have gone better. So we continued to work with DOH. After that first year, I think you guys sent out an updated data sharing agreement, and the tribes are like, wait, this isn't really an agreement. This is the state telling us, here's what you got to do if you want access to this data. And so the data sharing agreement work kind of came out of those conversations. And one of the things was that, and Sarah mentioned, not knowing how much data this agencies are already gathering that is tribal data, and finding a way to help the tribes and the urban programs know when these data are gathered, or when there's a data request, what DOH has, and then who they're sharing with it, and how they're sharing it, and what's the story they're telling with it. Because what if the story is not the story that it is? And so we developed this tribal data use form. Did I get it right? Yes. And kind of piloted it. But then, the talks broke down about the data sharing agreement. So we decided to go with the committee under GIHAC to move it forward, because we need to. So I think that sets you up for your part.
Yeah, thank you. And I just want to reiterate how invested the Department of Health is in tribal data sovereignty. We've actually written it into our transformational plan. So thank you to the Commission and tribes for the consultation that we did embark on. We certainly learned a lot as an agency. There are really two components to the tribal data sovereignty discussion from our perspective. It's access to data. And so really appreciated your comments, Sarah, just really understanding like the scope and the amount of data we have and what's important to tribes to access and utilize. And then there's the governance section. So what are we actually doing with tribal data, and do tribes know about it? And so we created this tribal data use form that would create a notification process. So as requests came in, we had a fuller discussion about the request and who wanted to utilize it, or did the Department of Health want to utilize it in some way, as Vicki mentioned, like to issue a report. So really excited about the Tribal Data Sovereignty Committee that GIHAC created. I think it will provide a way for us to talk about not only where we want to go, but real life examples as they pop up. And one of those being, we received a request from a state agency for data related to a tribal initiative. And as when we were in consultation earlier, a couple of years ago, we're starting to use the form to practice and see how it would work. And we haven't engaged in that process, but this recent request, we did reach out and to Vicki, and thought, this would be a really good opportunity to maybe utilize the committee to talk about if we get a request for data, how might we want to talk about that as a larger group.
And so I have the form from the Attorney General's office, and I asked them to be here too, because this was a good way to kind of help you guys understand how this might work. And I know this is more for the data committee, and we'll take it there, but Mike, if I can share my screen.
Hi, Vicki. I'll let you know when I can see your screen.
I gotta open up the document first. Sorry.
while you're opening the document, how many tribes participated, do you think, at the last meeting?
Jessica, do you remember?
It was a lot of really good dialogue.
Off the top of my head, I want to say that it was around 10, but it could have been a little bit more.
So clearly this document still, oh, is it not showing yet?
This is Mike. I don't see it yet.
Oh. Wonder if it, I know I was having trouble with the internet, so I went to my hotspot. Mike, I'm going to email this
It's
to
loading.
you. Oh, it's loading.
Yeah.
When my grandson was little, he used to say, "It's loading."
I know. I can tell it's loading. I can tell it's slow. If you want to email it to me, Vicki, I
I'll
can
forward the email to you. Sorry.
tell it's trying.
Oh.
Oh, it just loaded.
I gave up it. Okay.
So I can see your tribal nation data form with the slash through.
So, and a couple of things, we've had a lot of conversations, especially with DOH, about gathering tribal affiliation. And we're going to talk later about a bill we have to exempt tribal data from the Public Records Act. And that's because if they collect tribal affiliation under the Washington State Public Records Act, if they get a public records request about data, they have to share that data. And that's something we found out in the process of talking about the data sharing agreement. And Asa, I think Asa and Lucy are on here too. They've been, working with the Missing and Murdered Indigenous Women and Persons Task Force, which has been doing great work. And the task force hired the University of Wyoming to do some data work. And so that's what this is, this data sharing agreement or this data use form is about, that request. And so we just wanted to, let you know, this is not something that's been implemented with all you tribes, but wondering if this is one of the ways that information about how data are being used can be shared with you and get input and feedback on that.
Vicki, this is Erin Ross from the AG's office. Asa had to step away, but I can just add a little more defining clarity to the AG's particular use of the data that we've requested from the Department of Health. One is that our team and what is going into the report recommendation, none of that will have tribal level detail. We are only going to be able to see aggregate data as it relates to American Indian Alaska Natives. The disaggregated data that the University of Wyoming will receive is only going to be held and seen by one individual. And that individual has just submitted her fingerprints yesterday for a background check. But we, like the AG's office, we will not have access to that disaggregated data. Anything that talks at a more fine-grained level about our relatives, that is something we will not be able to see, and nobody else at the University of Wyoming can see except for that one individual who's passed a background check with the Department of Health. So that is the purpose. That is what we're using the data for, is to track trends. But that is something that I would advise tribal leaders to think about, is the level of detail and how fine-grained the data can be, and whether that really is something that they would like collected and have access to the public eventually. We are doing our part to make sure that if there's a public records request on the data that we're using, that there's nothing in there other than the general trends for our population.
Thank you for sharing that, Erin.
Yeah.
So, and we'll bring this to the Data Sovereignty Committee, but I just wanted to let you know that this is kind of some of the work that will happen there too. And just that I appreciate how much Department of Health has been the effort they've been making to try and be more transparent and let the tribes know about when they're using data or when data is requested from them. I don't know if you have anything else to add.
No, thank you. And I think, part of it is the discussion, right? That information was so helpful, Erin. Thank you. And I think we just want to bring more transparency, awareness, and consent to the process. But, so thank you to GIHAC for creating the forum.
Yeah. And then the second half is where the tribe responds. So you see how the data are going to be used, and then you can respond, describe how this request is consistent or inconsistent with tribal sovereignty, describe how the request is respectful of AI and tribal culture, not respectful, describe this request dispels or perpetuates negative racial stereotypes. So really getting at those issues that we've had with our data when it's been misused in the past. And so I'll just stop there, but I just wanted, here's a real life incident that kind of came up, and it's good that it's between DOH and our own Attorney General's office, even though it's a third party, just so we can understand. So thank you, Kristen. Thanks, Erin, and whoever else. I know Lucy and Asa from the Attorney General's office helped.
On the form not the form, but when that bill comes through, is it just for healthcare in the Attorney General's office? Or is it all state agencies?
Because GIHAC is about health, we focused on the agencies that are part of the Governor's Indian Health Advisory Council. When we created the Governor's Indian Health Advisory Council, we didn't really work with the Attorney General's office very much, so they're not on there. And so there's also a bill about that. But we'll talk about that after lunch, I think.
Are there any questions or suggestions? And then lastly, those that haven't joined the committee yet, who's the contact person?
Myself or Jessica McKee at the commission.
Are there any questions for the data sovereignty?
And I would say that we sent the invite out to the commission delegates and the GIHAC members, and some of those are different. But also if you have somebody at your tribe, I know Lenny, you guys have Dr. Frank James, send whoever. It's not like this where we need a quorum, because that body's going to make recommendations to this body. So send whoever you feel is your expert. It might be somebody different depending on what the subject matter is during the meeting.
Perfect. Let's see, it's 11:33, so we're right on schedule. So I'm going to turn it over.
Summer.
Oh, go ahead.
It's Maureen Kinley. Just real quick, when is the next meeting, Vicki?
So next Friday, which I believe is August 23rd, from 10 to noon.
Okay, thank you.
Mm-hmm. And if it's not on your calendar, I don't know how it couldn't be, but let me know.
Okay, let's turn it over to the opioid treatment in Indian country, the GIHAC Wellness Center in Swinomish Indian Tribal Community.
Okay, can we start? Good, okay. So Jennifer LaPointe, General Manager, Swinomish Tribe, and we are going to have our Chief Medical Officer here from our GIHAC Wellness Center do a presentation on some of the treatment components, but I think we wanted to first start our presentation a little bit more broad than that. We know, I think everybody here is kind of in the same position where we can have the most, state of the art treatment, and we can have best practices, and we can do all of those things. But there's that whole piece kind of even before that of getting people to access that care. So just wanted to share. I know most of you, I'm pretty sure all of you have probably been to our GIHAC Wellness Center, and you've probably heard multiple presentations on how we do treatment here. And you're going to hear a little bit more about that today, but we kind of wanted to try to expand and talk a little bit more about some of the other things we're doing in this response to try to give some new information. Because I understand from, 20 plus years of these meetings, everybody kind of gives you the same presentation over and over and over again. So we're going to try to share a little bit of new stuff and see if we can spark some more interest and conversations. We're always looking for input. None of us can do this work, I think, alone, and it's constantly evolving. So part of our sharing is hoping that if any of you have any good ideas for us, that we can share that amongst each other. So like many tribes here in the Northwest, Swinomish did declare a state of emergency related to the opioid epidemic, and I think that's been pretty common here. Part of that was to started kind of a response task force. So we were really careful, really not wanting this to be another committee of our tribe that just met and had ideas but not actions. So one of the things that we were tasked with was to bring an actionable plan back to our leadership, and we did do that. And we have I do monthly, and then we do quarterly formal updates directly to the leadership from this group about the action items that we're doing, and also to our community. So we have a community Zoom meeting on this just to give them updates on this plan. More on that quarterly. And we try to do things that are, we can actually have real concrete action items about. The bigger Swinomish has been, at least to this point, very committed to the response to this problem being a public health approach. That's not to say that we don't have any law enforcement components or the punitive process isn't any part. Of course, we have to have that. Everybody has to have that, but we really view this solutions to this community problem through the public health lens, and we've tried really hard to make that statement. Our leadership supports that, and that's the approach that we have taken is response to a public health problem. So that's just kind of the framework. I'll talk about a couple of the things that we worked on. This group is actually, I don't have the detailed list with me. I'm sorry, I apologize. My computer's doing like the never-ending white circle, so everything you're hearing is from my mind. So bear with me. I think all of us do this work enough, though, over a long enough time. We should be able to talk about it without that. So this is my test today. We have of course, our treatment component with DGWH on that group. We also have our health policy on that group. We have our chief of police is on that group. Our public health officer, Sarah Wilborn, participates in that. We also have our head of social services in this group. So we've been really committed, and our legal staff, because one of the things that we found out pretty quickly, and this is something to talk about, is that we actually had tribal codes and other things lacking that really hurt our ability to accomplish some of our action items. And sometimes those can be slow moving to change. So some of the first things that we did really was look at, the first thing we did was start massive Narcan training, which I think everybody did that. We put drop boxes throughout the reservation, and we did a bunch of those things, but we still were experiencing where people wouldn't call 911. They wouldn't call the police, or the PD would show up and everybody was gone, right? So we really wanted to look back at what do we have in place for a Good Samaritan law, and how can we let people know, like, hey, it's safe to call. You're not going to be arrested on some other charge, all those things. So initially we were like, well, yeah, of course, we need to just let people know that's not going to happen. And even the PD was like, oh, we don't do that. We wouldn't, And then we looked at our code, and actually we were not in alignment even with the state Good Samaritan law. So We have done an amendment to our tribal code to remedy that so we can legitimately tell people like, hey, safety, health and safety first. Call 911. We'll deal with everything else later. We're not going to arrest you at the scene of an overdose or something like that. So that was important for us to look back at our tribal code and get that in place so we could truly start to advertise that and be honest with people about what was going to happen. The other thing that I think probably most of us are in this situation, we never had a true public health program or a public health officer who wasn't just another doctor there doing primary care who we put a label on prior to COVID. We do have that now. So we really wanted to start to bolster that program. We've done a lot of work there. We're hiring more people in that area. But one of the first things we realized is we had this, when we get this group together, one of the people that participates is Fire District 13. So I'm going to talk about that a little bit. But we talked about some of the data for overdoses, response, how much Narcan our police department was administering, those kind of things. And we had all this data everywhere, but it was not all in one place. And nobody knew that other people had these other parts. So there is a ordinance in Skagit County that requires mandated reporting of ordinance to the Skagit Health Department. There's nothing that required anybody to report to Swinomish Public Health. So we did put into place an official ordinance for our tribe that requires mandated reporting of overdoses to Swinomish Public Health. So that applies to all the tribal programs, applies to the citizens, and applies to other first responders working within our reservation. So the fire district now has that to be able to report these public health. They're already required to report to Skagit County, but now they report it to us as well. So these are just key pieces because some of those places are their hands tied. They just have to do it. They have to report it to where they're required to report it to. And we didn't have a requirement for them. So we were able to work that out. We're big believers and you cannot fix a problem that you don't talk about. So we really can't fix this problem if we didn't know what the problem was beyond anecdotal reports, right? So that's one of the things we did. I don't think we'd have any problem sharing that if anybody's curious about the ordinance we did for just getting the data into our own community. We do have that. And then we started working on one of the big things that we have done in this area. We've done this kind of for many reasons, but we have a fire district in our reservation, Fire District 13. They do all of our calls for 911 calls and first responder stuff. We've really over the past 3 years or so, 4, 5 years, grown that relationship really closely with our police department. We're very aware that those are the only two entities that are really working 24/7 on our reservation. They're the ones who are going to people's homes. They know what's going on. They know the places they're getting called to over and over and over again. And so they're not tribally operated. They're a regular fire district, but we've done a lot of stuff to develop a good relationship with them. And we actually have what they have is like a CARES program now where they are doing first response kind of intervention referral to treatment for calls that they go on. They're a key part on reaching out to people after instances happen. They're helping coordinate services and trying to get people to be proactive and seek treatment. So I really encourage if any of you have first responders responding to reservation who you don't have that tight relationship with, it's been very changing for us. They're great. One of the things they do, even for our elders, is they do Good Morning Fire District 13. So you can sign up with them and they'll call the person every day and be like, hey, how you doing? How's it going today? Just as a touch point. So they were 100% volunteer fire department and they do a lot of training there. So over the years, they've had a situation where they train people, but then as soon as they're trained up, they go get real jobs, right? So we saw 2 years ago, sir, working with Chief Weiss there. He lives right on the reservation. He lives right down the street from our tribal services, the chief, and he and the chief of our chief of police, and then Sarah really worked together on like how can we get him some sustainable funding to have some regular staff that isn't going to move on, because people. We know it's all about relationships, right? And if you have better relationships with people and they know you, they're going to trust you more. They're going to follow through with that service. So we started really wanting to get to a place where he had a few more key people that didn't just train and then move on. So we have done some grant writing and we've done some sub awards of grants to Fire District 13 to help them have regular staffing, especially for the CARES program. They're the first responders that respond to substance use and mental health calls. And they actually talk to everybody in the household, everybody in the family who's on the site, not just the person that they were called for. One of the big things that we are trying really hard to focus on in the situation of responses to overdoses is following up with the people who administered the Narcan in the home and the people who had to witness it, because there's huge trauma related to that. And I think sometimes there's only focus on the person who received the intervention. And so we've been really trying hard to work on, let's follow up with the people who were part of that bigger picture, because that's a huge trauma and can lead to places later. So those are some of the things we've been doing. We've been working on coordinating ROIs so that when the fire district or the PD respond to something, they can do the referrals to mental health and have other people do the long-term follow-up. I'll say one more note and then I'll let these guys, because I know we're on a time limit too. Related to the situation I just talked about us trying to really do a hard focus on the other people involved in any incident. We've really been pushing hard to do some family groups and some counseling and intervention for family members and who have somebody who's struggling and they kind of don't know where to turn. For a long time, that was offered out at the DeGualich Wellness Center, but it was not attended. And so we had some really conversations about that, about, well, these are not necessarily the people who think that they're seeking care. They're seeking help because they can't get someone else to seek care. So we moved those into our community center. They're ran by one of our tribal members. It's on a break over the summer here for a couple months because there's so much crabbing, fishing, other conflicts. But we'll be starting back up in the fall, I believe, by Holly. I think you're going to talk about a little bit more. Just trying to get family members to come down and do support. And even the first couple month or so, she was doing that. No one was coming. And then I think her aunt went out and kind of like personally recruited people. So we'll be back at that in September. So we're like, we just need places people can come and talk and be like, hey, what do I do? I don't know what to do next. So that's those are kind of some of the things that we've been working on, along with the treatment part. So I will let these two tell you a little bit more about what we've been doing recently in treatment at GIHAC, but thank you.
Thank you. It's honor and pleasure to be here and an honor to serve those in need under the Swinomish Tribe leadership. Next slide, please. As we said, many of you are familiar with the GIHAC services, so I'll try to speak quickly in the hopes that we have some time for question and answer about what may be helpful to the audience here. So in GIHAC's care from the beginning, founded by Swinomish Tribe leadership, it's the quality of care and compassion of care for the whole community has been a high priority. And most of the patients who come to us do so by word of mouth from what they hear from the experiences of other clients and seeing how well other clients are doing. That's their friend, their family. And over the years, some of the evolution in our program, things that we've learned over time through experience, are to have more of a harm reduction mindset. That's been an evolution over the years to make it easier to enter the program and be less eager to discharge someone. Find any way we can to keep them in the program and help them make progress. And evidence-based medication treatment has been part of it from the beginning, but we've been, continuing to evolve with the evidence over the years, and adjusting folks' medication and viewing it like similar to many medications. When the benefits of the medication outweigh the risks or downsides, then continuing the medication if the client is on board with that as well. And as I mentioned, tribal leadership, culture, and values has been a foundation since the Swinomish tribal leadership founded the organization, and has operated ever since. And we appreciate that in so many aspects of the care that we provide. Next. Thank you. And as many of you know, these are a breakdown of some of the basic services that we offer at GIHAC. And these are all highly integrated under one roof. So not only under one roof, but we do, in a variety of ways, work to avoid silos and keep everyone communicating well. And that's all in service to reducing barriers to our patients. And essentially everything here is addressing a barrier in one way or another, whether that is, say, a patient with chronic knee pain that is one of their drivers for continued use, addressing that in primary care, for example, can help them make more recovery progress. Or pregnancy services, we know that's a very high risk time for folks. So having more intensive services around that time is again, reducing another barrier to folks making progress as a family. Mental health care, as we know, the rates of comorbidity are so high in those that we serve. And if we're not addressing mental health right alongside addiction care in a low barrier way, then we're not doing as much as we can for those that we serve. Dental care, we have clients telling us that their dental pain is one of their drivers for returning to use or continued use. So addressing that and then giving them their smile back, giving them a smile that has an appearance where they feel confident in social settings or job interview is just so important to recovery. And cultural programs inform not only the leadership of the clinic, but our counseling and our culture-based groups. And that has been important in so many ways from the beginning. Transportation, again, that's been a part of GIHAC from the beginning, and it's been expanding in reducing that barrier to care. Legal services, integrating with folks outside issues and helping them address those as they make progress in recovery. Child watch, so folks with families are more able to access care. Housing and social services is an ongoing effort, both connecting people to existing services as well as overhauling a building to turn it into supportive housing that is, again, led by GIHAC and the Swinomish Indian tribal community. Next. And we view medications for opioid use disorder as a life-saving treatment to help folks stay engaged long enough and alive long enough to benefit from whole person care. And we find, unfortunately, that many folks come to us bearing a lot of stigma related to methadone and buprenorphine, and that has been a barrier to entering treatment and sticking with treatment for many that we serve. So we try to address that through our care, and we encourage other community groups and anyone we talk with to work on reducing that as a barrier, that stigma against medication as being part of whole person care. And next. And some of the evidence behind, when we say medication is there to help people stay engaged long enough and alive long enough to benefit from whole person care. Methadone maintenance treatment reduces risk of dying by 69%, buprenorphine by 55%. And that's really a more powerful effect on saving lives than most medications available in the world today that we think of as important. It's really more life-saving than many people realize. Next. And we find that some of the barriers that are important to address, we found over the years, are misconceptions about addiction treatment. And one of those is that the concept of real recovery. And many folks believe that detox and inpatient treatment and outpatient recovery support without methadone or buprenorphine is inherently the best treatment. And we view whatever helps someone make effective progress in what's important in their recovery is the heart of effective treatment and the heart of recovery. And data show that detox and inpatient treatment with outpatient follow-up, unfortunately, 90% of the time, folks who go through that path without buprenorphine or methadone, when they have opioid use disorder, 90% of the time they return to drug use relatively soon after treatment. And a 2023 study showed overdose death rates were about 3 times higher for people sent to treatment, including detox and inpatient and outpatient follow-up without medication versus treatment with methadone. Next. Another misconception we address is the idea of replacing one addiction with another. That's both a barrier that keeps folks from arriving to us at all, and it's a barrier that a weight that many folks carry when they come into treatment with us. And our understanding over the years has been more and more that the heart of addiction is in the problems it causes in the individual community and the risk of death, and the heart of recovery is in improvements in the life of the individual and in the ways that are most important to that individual and to their community and family. Another misconception is the idea of graduating, the idea that tapering off of medication is inherently a success or a good goal. And our understanding more and more over the years has been that treatment with medication is a tool adjusted to the right dose for the individual. And if the patient tapers off the medication, it should be with the understanding that it's a tool that may be appropriate to resume if there's higher risk in their life, or if they return to use, or if circumstances show that they need that again, that they should be able to engage with their care team in a way that they don't carry the stigma of the idea that they graduated and they shouldn't go back. Like graduating from high school, you don't really go back. But if you need to, you should be able to go back to addiction treatment. And another misconception that can be a barrier is the idea of medication versus counseling and real recovery. I've gotten a sense in a variety of settings that sometimes there's a feel of adversarial relationship of us versus them kind of mentality sometimes between folks who advocate treatment without methadone or buprenorphine and folks who use methadone or buprenorphine as part of treatment. And we view that there's really no need for conflict because, again, the medication is there to help folks stay engaged in treatment and alive long enough to benefit from the whole person care that you saw on the second slide. Next. And these are just some of the references used in support of the talk today. And Eric, I believe Eric has some comments to share about integrating some of this care with other community organizations and some other reflections.
Hi, my name is Eric Ostergaard. I am the Substance Use Disorder Director at GIHAC, and I kind of wanted to follow what Jennifer was sharing about collaboration. And, thank you, Bryce, for the PowerPoint. It's so important for collaborating with, for us right now, we're really working with the courts and therapeutic courts. We have a wellness court on the Swinomish tribal community, and just by working and being part of and collaborating, we're in a spot now where they're looking at how we can incorporate, even though it's court and it's therapeutic court, we're looking at, that harm reduction and how we can not be punitive in a therapeutic court setting. Another is, we also go Holly Edwards, one of our SUDPs, Swinomish tribal members. She goes to Anacortes Community Court. Myself and an attorney, we just went to Skagit and met with the judge and probation officers and just collaborating and seeing how we can serve and just have better just that collaboration and the importance of us working together. And something recently also and non-recently, we also work with as known as detox withdrawal management. We have we have a good relationship between the Burlington or Skagit County Crisis Center and ITUA in our local area in Oak Harbor, so we can support Swinomish tribal members that are on medication and that there's no disruption in their medication while attending. And kind of going off of what Bryce was sharing about the statistics, it's really important, and that collaboration is very important. And also, the other is the family component, which is super important. And I do believe it's not in the fall. I think Holly has been out, but we are still continuing. So we are going out to the Swinomish tribal community 2 times monthly. And then we also still have one at GIHAC, and it has been picking up. And yes, Holly, that was a good move, and she got family out and she started getting participation. Before COVID, we did build our family group at GIHAC, and it was going well, and it took a while for it to build, and then COVID happened, and it's been a work in progress to get that back. But we truly believe, we have to have those doors open and continue to have those open to talk to family, because as Jennifer is sharing, a lot of people, they're wanting to help their family members, and they have a lot of questions, a lot of concerns. So our family group, we really tailor to who's at who's participating and what questions they have. And so we do have education, and curriculum, but we're really tailoring to the people that are there, and the questions they have. And a lot of times, what do I do? They don't know. Yeah, they don't know what they don't know. So it's just a great time to ask questions. And some of the times too, if it's a mental health question, we used to have mental health counselors there. And if the counselor doesn't know the answer, or if there needs to be more involvement, we'll definitely get back to them and get other professionals involved, so our questions are answered. The last thing I wanted to go over was something that we've learned from starting GIHAC to where we are now. Is we're always looking at how we can better serve the client experience and making it easier for participants to come into treatment. If that's having 2 appointments and combine those, which we did, we do that. We're always just looking at how we can cast the net bigger and capture more people that need help. And so we're always adapting to change and changing processes when we see the need. So thank you very much.
Thank you. And I see one of our senators, Senator Daly, has her hand up. Stuff to add for us.
Yeah, good afternoon. Thank you. I was just hoping that one of you would share about the apartments that we're working on. Did you guys hear me?
Earlier.
I was hoping one of them would share about the apartments we're working on.
Yeah, we'll do that. So, Swinomish tribe had owned some apartments in the kind of on the LaConner side of the bridge off, outside of our reservation, but right adjacent. And our housing authority had owned those, and they were, people lived there for many years under the Swinomish Housing Authority. And the issue that we had there was that we had it's very, very close. So if you've been over to the village side, when you go over the bridge into LaConner, the apartments are right there. But they are out of our police jurisdiction. So we own them. The housing authority housed people there, but we couldn't police there. And there started to be pretty significant issues over there with people dealing, using. We had a couple overdoses over there. We had different things happening. And we were trying to do any interventions that we could, but ultimately we couldn't police over there. So the leadership had a lot of discussions about this, and made the decision for our treatment component for DeGualich Wellness Center. At the exact same time, they were talking about constructing some apartments out by the wellness center for transition housing, basically clean and sober housing. So what we ended up doing was the wellness center actually purchased those out of the HUD program and is working on remodeling that apartment complex in LaConner to have supportive and clean and sober housing and transition housing. Our hope is that having that kind of structured housing will decrease our need to police it. So it was kind of like a win-win, and we can continue to have tribal member housing available there. As we went about that, we're in the process right now. If you drive by there, it's a huge construction zone. I think they have them like completely jacked up, and we're doing a complete remodel. But after we get that done, they will be managed by the treatment facility. They will be for Swinomish tribal members who are seeking supportive housing in that way. But in the process of this, then we ended up having the opportunity to purchase a house that's kind of in the same parking lot with that apartment complex. So we've actually purchased that house now, and we're able to develop some programs to have on-site kind of extension services of the DeGualich Wellness Center right there on the site with the apartments. So there'll be counseling there. There'll be some intervention people there. I don't know all the exact services that are lined up for that, but we will be able to have on-site immediate services there. We're talking about having 24-hour people there, because one of the things we found out with our first responders is they're like, we respond at 2 a.m. and then we don't know what to do. Like if people won't go to the ER or they just have nowhere to go, what do we do? So part of that house with the apartments that we're talking about is having a place for them to bring somebody to get a brief intervention. So that's kind of the nutshell version of that. I don't know if anybody here has anything to add to it, but we're pretty excited about this. We kind of took one problem and turned it into a positive, and we're able to still provide more housing for tribal members. And we did relocate everybody who was in that housing onto other housing on the reservation. So that took a little bit of time and like moving pieces and things like that. But we were able to do that. And so now we've actually are going to be able to open up additional housing to our tribal members. So we're pretty excited.
Is there a question on the floor?
Yeah. I'm sorry, I was trying not to, this is Charlene, I was trying not to jump in front of somebody who had their hand up. But I was the auntie and doctor parents group in Spokane, and I put him on the spot, doctor parent. And I heard somebody say Bryce, but if I was a doctor, you'd have to call me doctor all the time because I worked hard for that. It'd be Dr. Mom, Dr. Gigi, but one of the things I thought was, and I think is really important with tribally led groups and agencies and like Cedar Wellness presented, is I think the name is healing. So I wondered if you'd say what defoliation means.
So at the talk, I mentioned that I often present with a Swinomish tribal leader, and I defer to them on many such things. But since it was since I was asked, I'm told it means the place where the camas was dug. That it was a traditional place where camas was cultivated, thriving, and harvested by the Swinomish community. So it was, and that's the site where the clinic is located. So it was named after that. You get that right.
I also see Rep. Mossberger has a question.
Thank you. I appreciate that. Thank you for the presentation.
Yeah, she came out, got kicked out and came back in a couple of times, so hopefully she'll be back.
Can I add one more piece?
There she is.
Oh.
Go ahead.
Vicki, I think you were calling me back in. Is that correct?
Yes.
Sorry. Multitasking. I'm back now. Done with that last meeting. I'm sorry, what was the question for me?
We're trying to let Representative Mossberger answer a question, but I think she keeps getting kicked out of the meeting.
Thank you. I did. Yeah, my computer's my computer's insisting upon an update, so we're battling. The quick question is, thank you for the information. The building's beautiful. I wish that there were these all across the state. My question is that I'm really interested in the barriers to having people continue treatment, and I'm wondering, you've addressed a few of them. What we hear a lot, and I get emails about, is medical insurance, private and state, and then also people just leaving. And if they just choose to leave, are we doing an outreach, a follow-up with them to find out why they left? Maybe it's a barrier we didn't know about. So I'm trying to answer those questions. But thank you for the great presentation. This is great.
I think Dr. Perrin can talk about a little bit of the clinical barriers and how we overcome that. But I will say one of the big barriers that we identified, or two of the ones that we identified right away that we have pretty robust systems in now to address, is the childcare. I don't know if you noticed there's on-site childcare. That's a huge barrier that we addressed right away. So they can use childcare when they come in for their services, both medical services, dental services, counseling, any service that they're there for, there is on-site childcare to accommodate that. So that's one of the big barriers that we found for people. They just, especially if they're in the process of just getting their kids back out of the court system or things like that, they may not have a reliable place to leave them, and they're really nervous about not being the one in control, because if something goes wrong, they could lose that right so easily, and they know that. So that is, I think, one of the big barriers that we identified right away that we do. The other one, and I was want to, this could be its whole own presentation. So I think if people have questions, we're always willing to share about it. But transportation is the other huge barrier. And we do have a whole SWDOBS transit. It's like grown into like its whole own thing that helps with transportation to and from the services, and honestly, transportation to and from many other things around the reservation. And one of the things prior to this, we were really landlocked, right? Like if you had a suspended license or didn't have a driver's license or anything like that, you couldn't get anywhere, even out here to the casino from where our housing is, was like a huge barrier. And now you can ride that to work. So you can use it for a lot of things besides just going to and from your treatment, and people do use it every single day. It is also the thing I believe personally helps us put these services at these apartments that are really only a few miles away, but a huge barrier to people who don't have a car. So they can ride this SWDOBS transit out to the main clinic that you see the picture of. They can ride it out to the casino, and it goes on a regular basis. So our public transportation in this area just was not serving us. Coming through 1 or 2 times a day is not adequate. So transportation is a big one that we've been able to overcome, but it's hugely expensive. So anything we can help with funding on that, I think is good. But also just yeah, public transportation's a barrier, especially at the time in the morning we're talking about. Some of these people leave at like 5, 6 o'clock in the morning to come down and get their treatment services. So another one that we've food is a big barrier. People, when they have to leave, their house for multiple hours a day to come receive their services, there's not good access to food. So one of the things we've been able to offer is some of our incentive programs are based around food and offering lunches, or I don't know all the details, but I know there's like a take home pizza situation that happens sometimes. So bag lunch. So there's been some of those things that we've done as helps, but I think that if the clinical barriers, Dr. Perrin might be able to add to that.
Thank you, Jennifer. I appreciate that. And so part of the question about when folks are leaving treatment, do we reach out? We do. We have both a Swinomish Tribal elder on staff who reaches out in a very warm way to check in with folks even before they are discharged from treatment for not showing up entirely for long periods of time, even if we just haven't seen them in a couple of days. She's reaching out and to welcome them back, and we have our direct patient care staff, including our substance use disorder professionals, also reaching out to folks when we haven't seen them in a while, letting them know, okay, we'd love to see you back, and we're heading toward, you would be discharged through our routine processes if we don't see you, but we'd love to see you back. Our medical department's doing that. Our addiction counseling department's doing that. A couple of other things, we're increasing our case management staff and peer support staff. And part of what they'll be tasked with is being like even more proactive from day one, from somebody walking in the door to learning about that unique individual and what their barriers are to sticking with treatment, and trying to address those before those barriers lead to them falling out of treatment. And a couple of other general barriers to these kinds of treatment thriving that I'll just comment briefly on and then welcome Eric's thoughts. One of those is we've had, it'd be helpful for GIHAC and similar programs to have pharmacists who can, within the law in Washington State, under a collaborative drug therapy agreement with a physician, they can do certain types of medical care visits that are very appropriate for a pharmacist, like adjust someone's dose of medication, for example, once they've gotten training in the kind of work that we do. So they're legally able to do that work, but our understanding at present, they're not functionally able to bill for that work when they're the ones directly doing that. And that would be helpful because, as we know, there's workforce is always a challenge in addiction treatment, and to be able to have pharmacists and medical providers doing different aspects of the care would certainly significantly increase the pool of people we're able to recruit from in the region, and help our staffing, and therefore help how many folks we can admit to the program and how well we can serve. So, and then another thing that's really a complex thing but worth working on is to bring us closer and closer to no wrong door to a full range of addiction treatment. And in that, partly I think of a lot of institutions that are not legally able to provide methadone maintenance treatment themselves, then are not presenting that as an option, and their number of settings, for example, in ER can get somebody started for 72 hours and hand them off to a facility like GIHAC or an inpatient hospital can, but the rate at which they're offering methadone as one of the highly effective options for a patient to consider is not what it should be. It should be offered every time to someone with opioid use disorder, and then there should be a smooth handoff to an appropriate clinic in their region that can continue that care. And there's a lot of room for improvement in that, as well as integration of the full range of addiction treatment availability in all care settings, because people that we serve encounter just really basic barriers in our healthcare system, because of course those that we serve don't only come to DGWH, they need our full range of healthcare services. And they could be, say, admitted to the hospital for any number of things. It could be a broken leg or whatever it might be. And then they need to get discharged, let's say, to a rehab facility or a skilled nursing facility. And when they're discharged, very frequently they are denied admission to a wide variety of service facilities. And sometimes it's pretty clear that they're being denied because of the medication they're on, because they have opioid use disorder. It's not always stated that way because these facilities are aware that they're not supposed to deny people admission, but just getting more access for our patients to be able to thrive in all aspects of our healthcare spectrum of services.
Thank you. So I know we're the only thing standing between everybody who's in person and lunch, right?
Had a comment. What a great presentation. We really appreciate it. And we're excited about, are you still doing the tour after today? Is that a yes or is that?
That's a yes.
Okay, perfect. Great. Good job, you guys.
I'm sorry, can I ask a question though before I know it's lunchtime. I can smell it. On that last issue, Dr. Parent, is that education to other providers? Is it working with hospitals? I know that stigma and
like what ways do I think might be positive in addressing that?
Yeah.
And that another example of that is inpatient addiction treatment facilities. There's been some progress in that over the years, but there's still many facilities that don't effectively welcome folks on methadone into inpatient addiction treatment, even if they nominally do. I mean, that's kind of a long story that I won't go into for time, but what comes to my mind is, and I welcome others' thoughts, but what comes to my mind is thinking about what leverage points the state has with different types of institutions. I mean, and what funding these institutions are receiving, or what licenses they have to renew, or thinking of ways in which the state may be able to use those points of funding or licenses or other points that all these institutions need to maintain, to say, okay, to maintain that, you need to keep up with best practices in welcoming and caring well for people with substance use disorders.
Can I add to that? I think that this is a really important issue for us to pick up with this group at some point as a statewide, like what Dr. Parent's talking about, more emphasis on this for everybody who's receiving different types of funding, because many of us are in areas where we already only have a couple of choices for these types of facilities for people to remain somewhat close to home. So if it's an option for them to deny you based on the medication that you're on, that's a huge barrier for people having to go further and further and further away from home in these rehab facilities. If there's only a couple options in your area, it may not be as big of a problem for places that are a little bit more urban located and maybe have a lot of choices. But really here at Swinomish, we only have a couple places for rehabilitation or long-term care. There's only like 2 or 3 choices. Some of them are all ran by the same organization. Maybe there's like a Mount Vernon site and a Cedar Woolley site, but they're really ran by the same organization under the same rules. So if we don't want people to have to go to Arlington or Everett or be way further away from home for that type of care. So just want to add that.
Thank you. I know Maureen we'll take one more question and then we'll break for lunch with a blessing from Anybody that wants to step in and do the blessing after Maureen? Erin? No.
Thank you, Summer. This is Maureen. I want to thank you guys for all the work that you do and the compassion and the commitment that you have to the Swinomish community and surrounding tribes, because I know that we have Lummi tribal members that also come down here. But I did have a question on the ordinance that you mentioned, the mandatory reporting. I would like a copy of that, if possible. And then that's on reservation, right? That's okay. So I'd like a copy of that. And then in regards to the codes that need to be changed as a result of the fentanyl crisis, because we also at Lummi declared a fentanyl emergency. And that's one of the things that we're struggling with is changing the codes quickly because it is not a quick process. It takes a long time. So I'm wondering if you had any suggestions for that. And then in regards to the housing program, we too have housing, but it's gotten to the point where I would like to see your guys' structure. You can share that with me later. You don't have to do it now, but I'd like to see your structure on how that's set up because we do have our HUD housing, but on the health side, where there's a bigger need there. So if you're willing to share that with us as well, that would be helpful. We're just getting to the point where we're setting up that structure, and if I know that Tulalip is also doing that, I would also like a copy of your guys' structure as we're moving forward. And then the other thing, if you're willing to share, is your organizational structure, how that's set up, how many counselors does it take, your medical staff, all of that. If you could share that with Lummi, that would be greatly appreciated. And then, going back to what Vicky had talked about earlier, the education with our surrounding hospitals. If we have somebody show up that is using, we shouldn't treat them any differently. They should be treated with the utmost respect that anybody else would get. So I'm wondering, if there's any education that you have with the surrounding hospitals. We've had incidents, at our local hospital. So I'm just wondering if you have anything that you can share on that as well. So thank you.
So, Maureen, yes, 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 yes. We could definitely work together on sharing things. I think none of us want to reinvent the wheel. There's enough work to do without redoing the same thing that each other's doing all the time. So we can follow up with you on that and start getting some of those things over. We'll start on our list of things we want you guys to share because you guys are doing great stuff up there. So maybe we can do a little bartering here. Hospitals, we are just starting that. We have the same issues. We talked a little bit about our CARES program and the FD13, and we've been really working with them and training them. They're the ones bringing the people directly to the hospital in the ambulance, right? And then they're coming back to us saying, we tried to pick them up because what they're trying to do is when they drop someone off, they're trying to go back and get them and give them a ride over to DeGual but the hospital doesn't notify them or notifies them after the person went MIA. So we don't have the solutions for that, but we know the problem and we're really working on it too. So maybe we can have some talks about in the future here about what your issues you're seeing and we're seeing, and maybe we can try to get same as I think Bryce brought up about some mandates on some of these long-term care facilities and rehab centers, some help with hospitals and what expectation they have to help us make sure that this loop is closed, I think would be a good future conversation.
Thank you. Erin, would you offer a prayer for us?
Yeah, I can offer a prayer, but I want to ask our Swinomish host if okay to sing a Chupik song for our lunch. Because I can sing one. It's a blessing song. So this song is a blessing song. Generally, it was when it was first made, it was for blessing our tools as we go out to provide for our families, but it's been used to provide for all of us, for all the tools that we're doing to provide for our communities as well. So stand up and pray in your own way. Dagwag naram kaan wi ahang aiyaha. Dagwag naram kaan wi ahang aiyaha. Ashuach shutan kan pikani agnia tutkarang ya achang aie achna ichia darvar naram kan wi achang aie Ashuach shuten kan pikani agnia tutcharang ya achang aie achuna ichia.
Thank you, Aaron. We're gonna break for lunch for the online participants. We're gonna come back at 12:45 for working lunch, and then we'll conclude at 1:30. Okay, everybody, we're going to get started again. So next, we're going to talk about the legislative health priorities and then close it out with the 2025 Washington State Capital Budget investments. Turn it over to Vicki.
Yes. Good afternoon again. Heather's not here today. She's on leave. So I'll be subbing in with Representative Lechanoff here. I'm trying just both in the, I don't know. Oh, let me turn off my background. We're gonna look like we're in the Matrix. Okay. So we've already been at work thinking about what's next for the next legislative session. There were some things that we've been working on that didn't quite make it into the mix last year. So you might recognize some of these. If you go to the next slide, Mike. We've had an ongoing conversation about Medicaid fee-for-services program parity with the managed care program. And so we've really been trying to think of what we can do to help make sure that when increases happen to managed care program for Medicaid, that the fee-for-service program is receiving some kind of parity. It had gotten so bad that the difference in reimbursement now means that there are many providers who don't accept fee-for-service patients. And then, the second one that we've been talking about and not really been able to figure out how to leverage any kind of corrective action or any teeth to get the hospitals to stop releasing people when they're in crisis. And so we'll go more into that. And then the data protection one that I mentioned earlier, exempting tribal data from the Public Records Act. And support of the Tribal Foundational Public Health Services. And I know somebody mentioned about having I think it was Jennifer, about having public health staff now. And I know that that's been true for a lot of the tribes coming out of the pandemic, realizing how much that public health work was important to their communities, and then getting the FPHS funding that was set aside for the tribes. So we'll talk more about that. And then, as I mentioned earlier, updating the Governor's Indian Health Advisory Council membership to include the Attorney General's office, because now they're a partner in a lot of our work because of the missing and murdered Indigenous women and persons and the opioid task force and many other great things they're doing. All right. So I'm going to go through each of these, and if you want to ask questions, go ahead and stop us at any time. So next slide. So the intent of this would be to address access barriers for Medicaid enrollees in the fee-for-service program. As we all know, the federal law exempts American Indians, Alaska Natives from having to enroll in Medicaid managed care. In Washington State, that means that more than 60% of the American Indians, Alaska Natives enrolled in Medicaid are in the fee-for-services program. The payment parity has not been maintained. I know there have been some efforts, but it never seems to work out. And I know that the managed care organizations have really good lobbyists. So we need to stay in the conversation on these. And so the lack of parity has really resulted in significant barriers for American Indians, Alaska Natives. On a side note, those tribal federally FQHC agreements can help with that, can help bring the encounter rate into the equation. But we just want to make sure that our people, who are some of the most vulnerable people in the state, who are Medicaid, have access to the same providers as other Medicaid enrollees have. Previously, and I don't know when or why this stopped. If you became a Medicaid provider, you were a Medicaid provider for both managed care and fee-for-service patients. And that changed somewhere. Nobody seems to know why or how. It's a big mystery. I keep asking if anybody knows. We're still looking for the answer. But so we think one of the solutions is that through legislation, that when a provider fills out the Medicaid core provider agreement, that they're required to accept both managed care and fee-for-service as they used to be able to, or used to be required to, and not discriminate against the fee-for-service patients. So
before we shift gears on this one, Vicki, correct me if I'm wrong, but you've reached out to Chair Rivers and also to
Chair Cleveland of the Health Committee. I think we have a meeting at some point. Senator Robinson, and also I've had that conversation with Senator Cleveland and Representative Riccelli when he was the chair. I guess he's still the chair until the election, right? Yep. So they know, but we've never really come to what can we do about it. I've even asked that let us build some intent language. So whenever they have a bill about Medicaid, that it talks about the intent of maintaining the fee-for-service program that is still used by, again, some of the most vulnerable people in our state.
So maybe for Senator Robinson, the meeting that we'll have with yourself and Cleveland, sorry, not Rivers, thank you, with Chair Riccelli. I've reached out to Mary Clogston in the House side and asked her to reach out in the Senate for Lynn to do a little bit of background on the question of when did this change and what are the barriers and what are the options for the senators in healthcare and the House representatives of healthcare to take find. Representative Stearns is the representative for GIHAC here, so we'll also make sure.
Are there any comments or questions about that? Senator Robinson?
Thank you. It would be really helpful if HCA, and maybe you've already engaged them, but it would be helpful to get options from the agency. I mean, we can kind of have stuff.
So engage the agency in developing the language or the options?
How to solve the problem. And if you've already done that, I apologize.
I think what we're trying to do was find out from OPR on the Senate and the House a little bit of background, and then go back to the agency, find out what the options are.
I think it's important to understand when the change happened from being a core provider and accepting both programs and what caused that to happen. And I think the Healthcare Authority seems to know. And I haven't found anybody in the legislature who knows. So if anybody knows, we'd be happy to hear from you. When the change was made, it used to be if you filled out a core provider agreement to be a Medicaid provider, that you became a provider for both fee-for-service and managed care. It used to be Healthy Options. Yeah. Okay. Any other?
So I'm not advocating, but I'm saying when you're looking at this, if you're looking at the fee-for-service system, it's probably good to put some scrutiny under case management as they're going through a fee-for-service as well.
Yes. So if a patient is enrolled in managed care, they get a lot of other services through the managed care organizations. We've been talking about primary care case management and primary care case management entity to try and bring some of those services into the fee-for-service program to tribes. And that's outside of legislation. Oh, sorry, I'm not in control of the slides. Mike, can you go to the next slide? Oh, sorry, Sarah.
Just a quick question. So, as you know, so Swinomish serves non-natives on our opioid treatment program side, and I didn't know if this legislation um, kind of attached any language or even the discussion item of us getting paid in a timely manner and being recognized as an in-network system. I can't remember under Healthcare Authority if we're automatically recognized in statute because it's a lot of money that we're needing to pay.
We just finished up working with the Office of the Insurance Commissioner on issuers guidance, updating the 2014 guidance that we did with the rollout of the exchange and the ACA coverage. And so they're going to put their logo on that, which is a big deal with ours. And then we're going to send it to the issuers. And then I've already reached out to Johnny Schultz in Healthcare Authority. And we've been talking to him about the same thing with it. And they're the same laws. And so some of them will apply under that guidance, but there are some very specific ones to Medicaid. So we're going to do that same issuers guidance because the laws are already there. It's just that they're not followed. Yes. All right. So hospital tribal crisis coordination. Every time we have a conversation about behavioral health and crisis, we hear this story where a tribal member is taken to the hospital ER to wait to be seen by the DCR and assessed if they need involuntary treatment admissions. And before the DCR is even called, the hospital staff determines that they don't even need to be seen by the DCR. And in our minds, this is interfering with the RCWs around involuntary treatment. So 7105, but also 7134, which is the youth. So yeah.
Oh man. We brought up hospitals. Swinomish, I believe, was the one that brought up hospital issues too, or surrounding community hospital. And I know I've addressed it so many times. And we were the first to get a tribal designated crisis responder. But what we noticed too, it's great. They became a crisis line. We get a lot of phone calls, but majority of it is voluntary now. Like they want to get help, but we do still have problems with the hospital. So we've been trying to navigate, do we do an MOU for everyone or do we make sure the right verbiage is in the care coordination agreement?
Yeah.
The tribal DCR, she's a tribal DCR, but she's also used for crisis. So she'll go to the hospital with them, but then she'll go to another crisis. But in the meantime, the hospital's not getting back to her that they let them go. So there's not any communication or follow-up. So our tribal members get lost in the system and they get to go home when that could have been another addiction, but if we had better communication, then we could work with our MAT program to try to get them in, to box them in for detox. But we feel like the hospitals are not caring about our people because they just look at them as addicts only. And they put them back to the end of the list. And then sometimes they're like, oh, I'm healthy enough to go home. So they end up checking themselves out without the follow through back to the tribal DCR. So I appreciate the involuntary,
but that's covered under the bill we passed last session, the House Bill 1877. I think we just need to work on implementing it and making sure that the hospitals are informed that they're required to notify the tribe and the Indian healthcare provider if something changes with their tribal member when they're in the ER. So, yeah.
Is this a legislative fix that needs to be done or perhaps?
Well, yeah, I just ask questions because there is that care coordination agreement that Healthcare Authority is working on. And I don't know if it's different than a care coordination for crisis, so
it's
if they're
very
separate,
clear
then
under the new law that there are supposed to be sharing that information. And Kelly's been one of the people who has been telling us about this issue with the emergency room, and she's a tribal DCR and even can't get information about the patients that she takes there. So, or
well,
sorry, Charlene.
Nobody will take responsibility. That's why we want this bill.
Okay.
Or can, or feels like they can. Sorry. So we have option A and option B that we're thinking for legislative solutions. And option A is that legislation that requires hospital staff to comply with all the requirements that DCRs must comply with under 7105 and 7134 and defer to the decisions of a DCR. And or option B, and maybe we need both of them, I don't know, prohibit hospitals from using non-DCR staff to perform DCR functions, which is what they're doing. And I know the hospitals won't be happy about that. But we've not been happy about their treatment of our people for a long time.
I have a question. So I like option A as we're looking at this, because the question on the legislation that was passed last year was a sharing of information. Does that preclude working with the tribal DCR other than sharing the information with the tribe? So the working with aspect, I think you're looking at that complying with all the requirements that DCRs must comply with. I think if we're able to make that bridge between just the sharing of information versus working with a tribal DCR in crisis, that's the difference, right? And I think that does probably require a legislative fix for the working with aspect.
And I think Brent has a question or comment. Brent?
Yeah, I this is the first I've looked at this. The biggest problem, Vicki, is there's no DCRs. They're hard to find. The certification's kind of difficult. Right now they're being poached around, because everything's being driven in healthcare by supply and demand and who will pay more. People are poaching each other's DCRs and they're moving all over the place. And so the only thing I would be worried about, I like DCRs. I think they're great. I just think, like MSWs and other things that we have in the state, we have a shortage of them. And I don't know how to fix that, because we do have some new classes that were offered at Peninsula College. I'm not sure if DCR was one of them, but we need some of that. If we want to go down this path to having more professional people perform DCR functions like a DCR, then we need to provide some sort of incentive for community colleges to get more out there in the field.
Yeah. And so the DCR training happens through the Designated Crisis Responders Association, the Washington State one. And I think it's a 40-hour training. And then you have to meet certain like licensure criteria in order to take the training and become a DCR. And then when we passed Senate Bill 6259, we established that a tribe can also work with the healthcare authority to appoint their own DCR. And I don't think we're going to solve workforce issues here. What we're looking to solve is to not have the hospital release people without working with the tribe. If the tribe is trying to get information about their own tribal member who is in the ER, and the hospital is saying, I can't talk to you because of HIPAA, and we all know that's wrong. But also they're saying our MSW looked at them and said they didn't meet the criteria for them to call the DCR, which is like working around the situation. So that's the purpose of the bill. And I think we do all agree that workforce is an issue. And yes, this will not make the hospitals happy.
Well, it's going to be difficult.
Yes.
It's a mess in the emergency rooms right now. So.
Well, and there might be a better way to say it. I don't know. I'm not sure that you're more tactful than me, Brent. So
I'm totally not tactful.
Neither one of us are very tactful.
No, the emergency rooms are a mess, absolute mess. Yes. And the problem is they very quickly look to unload people anywhere they can.
Mm-hmm. Yes. Yes. But if a tribe has a DCR, you would think they would want the DCR to take over that care instead of just releasing them. I mean, we've
they would absolutely do that. Yes, I think they would.
Tribal. So with the legislative back, and I defer to my senior senator here who's done this a lot longer than I have. So I would think that the piece of legislation we're looking for is if a tribal member is in a public or private hospital, ER, and that it is mandated that public or private hospital must contact the tribe and a tribal DCR.
We already have that law in place and they're not following it. This requires them to follow the Involuntary Treatment Act. And so if they have staff who are going to say, this person doesn't need to be seen by a DCR, they need to be trained to do that. And the training is the training that a DCR gets, and them following the RCW under 7105 and 7134.
I was going to say, through an MOU, say it's Skagit and Swinomish, right? So if there's an MOU between Skagit and Swinomish, if Skagit didn't have a DCR, didn't have that, they would pull the tribal move there until a tribal DCR came, did the assessment, and that way it also impacts the. I don't know, but I'm trying to think outside of the box as I start thinking.
We've been working on this for years. All the boxes have been thought outside of. I mean, this is the what we've come to after everything we've tried. They are. The sharing of information, care coordination. Yes, Jennifer.
Vicki, I think there's like a two-pronged problem. The problem is they're not following the law that's already in place.
Right. Yeah.
So I guess the first question is, what kind of teeth or what do we have support to make that happen? I think that's the first piece. And if that were to be followed, do we even need this other fix? Or are we just trying to make a workaround and get a second rule that they probably won't follow either? Which one is it, or is it both?
I think it's both, really. I mean, so can something happen to their license? Sure. Okay, what happens if a hospital just decides to stop doing emergency care or whatever, So I think we've been trying to think of ways to get the hospital's attention, to make them understand what they're doing, because their practice, much like the managed care organizations, violates laws, but they continue to practice that way. And so, yeah.
Well, but keep in mind, Vicki, in large hospital systems, like in the urban areas, a patient comes into the ER. They don't necessarily identify as Native American. They don't identify what tribe they're with. There's lots of things that make it very difficult for the ER staff very quickly trying to ascertain what to do. And so there's a lot of issues. I mean, in our area, it's a lot easier because everybody knows who everybody is.
Yeah. And also that some of the, most of the hospitals, I think, hire in the rural areas somebody to run their ER who's not really the hospital staff as well.
Almost all of them do. Yeah, that's correct.
But these times when people are being released, or is when the tribes are trying to get information about their person so they can help them and know if they're getting released and they're still in crisis, to come provide services to them or bring them back to the reservation and make sure that there's a safety plan and all those things. And they're not allowed to let that happen because the hospital is releasing them and not telling the tribe. Even tribal law enforcement has gone to the ER and asked, and they were told, we can't tell you because of.
Well, but I don't understand, Vicki, is if every one of our patients that's a patient at our clinic goes to the emergency room, we get a report the next day, the very next morning. So why is it that a tribe can't get, are these not their patients? Their own tribal members?
They are. I know, and
they should be released.
The hospitals know how to track us down to bill us for our patients when they go to the hospital. So I know that they know that they're tribal members, right? So that, and we, in the 1877, we put reason to know that they're a tribal member and have an Indian healthcare provider, because again, I know they know how to bill us. I ran that program for years. They also knew to call us if is this person Elwha or Port Gamble or Jamestown. I mean, they can figure
it could be the hospital. Some of the hospitals have different electronic health records than the tribes.
Do you have a good contact at the hospital association?
I have talked to just red hair.
Eric Lewis is still there.
Not you. Can't think of her name right now, but their governmental affairs person.
Shalene Whitaker.
I'll get back to you on the name.
Okay. Well, I just wondered if you have a working relationship there, because
not a very good one, because they didn't like what I said.
If you've already legislated around this and they're not implementing, that might be a space to try to work out issue. I don't
Well, I mean, we don't want to have to write another bill and try and go through that process if something would work out. We just have not. There's the healthcare authority doesn't have a way, Department of Health doesn't have a way to hold them accountable. Who has the power to do that?
Yeah, I mean, I get it probably is DOH, but it's definitely hard to do. I'm not saying it's easy.
Well, at one point I was like, screw it. We're just going to teach everybody how to do a grievance and let them send all the grievances to DOH, because let them, see all of these stories that we hear. We meet every Thursday morning to talk about the behavioral health crisis, and this comes up every week.
Hey, Vicki, this is Jane. Is the law that you're referencing codified in the hospital licensure chapter, or is it codified somewhere else? Do you know where? I know I haven't tracked.
I want to say it's under 7105, but I'd have
Yeah. Yeah, you might. I mean, because chapter 7041 is the hospital licensure chapter. And if you want DOH to enforce it, then it needs to be like a condition of licensure, right? Because they're going to enforce within their chapter. So it's just something to think about.
Thank you, Jane. I always appreciate you being here.
Okay. Yeah, it's just something to think about. I think it's really hard. DOH is, and there's folks from DOH, I'm sure, on the phone, but they tend to focus more on sort of, and this is clinical. It is clinical, but their jurisdiction is within their chapter.
And just, people are dying and have died for decades because of this. So I think we're just desperate for a solution. So if you guys can come up with something and we don't have to write a bill, that would be great. And then maybe this was our way to get your attention.
I'm with the Department of Health, as you know. Definitely interested in further conversation, Vicki, to see if there is. Jane's absolutely right. As always, this is under 7105, which is Behavioral Health Services chapter. But we do have regulations and laws around discharge and other responsibilities that we enforce for patient safety and access to care. So, there may be an avenue. Vicki, I don't know how much the department's been involved in conversations with all of you over the years. I'm sure we have been happy to look at it.
Yeah, I'd be willing to convene a meeting with you and WISHA and DOH and just talk about it and see.
I have a bunch of friends I'd like to bring.
Yeah. Would you mind reaching out? I will. And then we'll figure out a time.
Awesome.
At least that's a start.
Yeah.
I know. Oh, sorry. I know Deb had her hand up a little while ago, so I just want to.
No, that's okay. I know that we have just a few minutes to get through a couple, and I would like to follow either Senator Robinson and coordinating the meeting following up American Indian Health Commission. Yeah. Okay, that's great. Thank you.
Sorry. That this is Charlene, that if we want them to be gone, then suddenly, oh, this is your sister. Sure, you can go with them without ever checking or knowing.
Oh.
Yeah. Just
in answer to your question, Kristen, the DOH unit that enforces that chapter already said it has no teeth and doesn't relate directly to this issue. Jennifer.
Will that be covered under new dental efforts?
So while we have a good offer here right now to get us a meeting with the Hospital Association and the DOH, I would like to have us consider, I know it's not under the same rules up here, but start recognizing behavioral health for what it is, behavioral health, not just mental health. Because we need the same kind of notification when people overdose and end up in the ER and then you discharge them. Yeah. Because we could bring them directly to our treatment facility, but we have I told you earlier, our fire district and our PD and others bring someone to the ER and say, notify us when they need a ride back home, and nothing. I mean, and I understand people leave against their advice all the time. It'd be good to get some notification that said, hey, they left. Sorry. So if we're going to get an opportunity to ask for that coordination, I think we should include the substance use component too in the discussions.
I had that conversation with Dr. Parent before he left. So yeah. Okay, so meeting with the hospital association, maybe not a bill. Department of Health, you or your provider, whoever you choose to send, and then anybody else, let me know. But I know you guys should be there, and Kelly.
Great. Just a reminder, we have about 10 minutes left.
I know.
Can I say one more thing? I just want to be on record that at Swinomish, we do consider overdosing and use a crisis.
Yes. And to not think that is stigma. Next slide, please, Mike. The Indigenous Data Protection. I'm not sure about the name because it was Tribal Data Protection before, but this is the bill I was talking about where if the state gathers very specific data about your tribal members, like tribal affiliation, under the Washington State Public Records Act, if that data are requested, as long as it's not PHI, right, they have to release it. And so, as we heard, the Attorney General's office is doing this work with MMIWP and the boarding school report, and they have to be very careful about what they write down or record because it's subject to the Public Records Act. During COVID, the USA Today requested all of the Washington State data on vaccine distribution, and guess who was getting vaccine from the state? A lot of tribes. And so they had to disclose with the provider name and the amounts of the 3 different vaccines that each tribe received, which we didn't want them to do, but they had to because that's what the law says, right? And so this bill would exempt tribal data under the to exempt tribal data from being released under the Public Records Act. And we have the language written. And because those data actually belong to you, the tribes, and the story that should be told about them should be told by you. And so that's one that we've already written, and we've actually kind of shared it with some of the legislators in the past 2 sessions, and there's been a lot of data bills the last few years, and there has been some interest in this one. So we have the language ready for that if anybody wants to see it.
For the Representative Slatter did a bill last year on opt-in and opt-out on public records of your office, and then this year Vicki helped me draft this bill with Jason with our OPR staff. So Senator Robinson will send that over to your office.
And by Vicki, she meant Heather.
Oh, sure.
And this is Summer again. I just want to make sure, I'm pretty sure this is for GIHAC divisions, right? So all like
and so this bill, because we don't know about natural resources data. I got a really stern comment from Ron Allen about that. And so we don't want to mess with that. We don't really understand social services. So this bill is specific to the agencies that are part of Governor's Indian Health Advisory Council. And so I think if you go one more slide. Can you go one more slide, Mike? Next slide. That's why we want to add language to 4371B that allows the authority of GIHAC to add agencies so that we can add AGO so that they're covered, and that helps them with their reporting on MMIWP and the boarding school report that's being done and whatever else comes up in the future. I think that's it for bills. Next slide. Yeah.
Oh yeah, that was my question because the boarding school topic is so sensitive and sacred. And so, you know, there's collection of that information in databases is a little concerning. And so we have to kind of remember our teachings, you know, as we go through this, but how can we protect that data that is being brought, you know, together? So I'm hoping that I sit on one of those committees for the boarding school in under intellectual property and whatnot. We're always really super careful on what we put in databases and whatnot because anything if
the Public
you're
Records
working with
Act.
the state, yeah, the Public Records Act. So that will definitely help, but we also have to be mindful of, you know, the data that goes beyond just HIPAA.
Next slide. Did you have anything else? Okay, sorry. And then I just wanted to quickly recap the 2024 capital budget investments into tribally and urban operated facilities for behavioral health or OTP, and then talk a little bit about the planning for the 2025 budget capital budget request. And I think we can talk about other facilities in another place, but there are some facilities that the state owns that I think tribes should think about an opportunity to take those over and run them. Next slide. So during the 2024 capital the legislative session, we worked together with the tribes and heavily with the tribal lobbyists, I think, and got 13 different facilities funded. And these were shovel-ready projects to expand access to behavioral health care and that full definition of behavioral health care. It was over $80 million. It included feasibility studies, expansions, new buildings, inpatient, outpatient facilities, behavioral health, substance use disorder, and opioid treatment. So that's like the full menu of that. And thank you very much for that was hard fought dollars. We started at 100 million.
200, 100. I started at 200, was quickly reminded of our budget situation down to 100, but really, I think
then down to 50 and back up to 80.
Down to 15, back up to 80. But I really got to applaud the staff, both in the Ways and Means and the capital budget. It was a staff that really worked with Vicki and I to prioritize and help the tribes understand how we could best move these projects forward. Yeah, it was great.
And so these were shovel-ready projects to expand care in this year here. So June 2024 through June 2025. Next slide. So what that means is approximately 1,750 people access to outpatient services and hopefully about 150 inpatient beds in this year. Sarah.
Super quick. I know it's not technically under the capital budget piece, and we figured that out while we were making the request, but for those mobile medication units, I know there was only one-time funding in the last biennium, and the funding honestly wasn't enough for us to put all the effort in quickly, but we're working on our mobile medication units now, and that might be something I think that might need to be talked about because those aren't capital. Apparently, Representative Ramel said it's not capital, it's, you know, funding.
And then we'll be happy to work with the capital budget and the appropriations budget. And I think we got a really important person over here in the Ways and Means chair position here that probably heard us quite clearly. But yeah, we'll get that conversation.
Okay, next slide. And so in preparation for this next session, I did send out a survey asking, and it looked a lot like the form for the budget request, just asking what your current capacity is to provide different behavioral health services and what you're looking to expand in the next couple of years. And just any other information you want us to know. So I'll send out a reminder to those who I didn't receive from, because I'm sure that, and it's so low tech, it's a Word doc. So I was worried that, because I know that when I do a survey and I get to a question, I can't answer it. And it's like, how do I start over again? So it was just a Word document to just fill in the spaces. So I think that's it. Yeah.
I know we're going to go, so I'll be really quick. One of the conversations that we had at the first opioid summit, the second opioid summit, was that tribal leaders had said we need to stop competing for the funding because we're all helping the same people. So the prioritized list that would go to the capital budget, the Ways and Means budget, and the operating budget that was submitted and prioritized and kept in a category to share information with these was to stop the tribes from competing against themselves for funding, which was really harming rather than hurting us. This was the ask of the capital budget chair Theringer to please, for the tribes, let's work with the American Indian Health Commission to start submitting these each year in a structured manner. This year, the focus is on youth. I've had 3 youth proposals this year already. The Healing Lodge of the Seven Nations is asking for 8 million. Lummi Nation is working on a youth facilities as well, and Tulalip Tribe is working on a youth facilities. So that's 4, and potentially Snoqualmie. So we'll see how we go this year, but it's all in Vicky's hands and all her staff's hands and all the work. Okay.
Yeah. Thank you, everybody. And it is 1:30. Good job.
This is Summer Hammonds again. I just want to thank everybody for being online. We're closing out, everybody. So again, thank you, everybody. And we just get a reminder when the next meeting is again.
The third and final GIHAC meeting of the year will be December 3rd at Jamestown, right before we have our annual meeting.
Yes. Thank you again, everybody.
Candace,
will you close us out in a good way, please? Thanks.
Wait, real quick, Candace, can I just ask, does anyone want to tour DeGual-H? Because if so, okay. Okay, just wanted to check. Okay, so the first stop sign is the one at the end of the casino before the trading post, and then you'll go past one other stop sign on the South March Point Road. And then it'll be on the left. Feel free to park wherever in the parking lot.
Go to the end of the parking lot, turn right, stay on that road till you see it on your left. If you get to the end of the road, you went too far. Super easy.
Siam, Nisjalacha Siam. Thank you, Creator, for bringing us together today in a good way, that this work before us continues on through the next 7 generations as we inherit this from our ancestors. We are advised from our elders, our mentors, our aunties and uncles, our grandparents. We honor our elders and our veterans in our communities and take care of our children. Thank you for bringing us together, Aishka. Thank you. Go in a good way.
Thank you, everybody.